Response to the COVID-19 pandemic. In order to facilitate the work of our interpreters and ensure an orderly meeting, I would like to outline a few rules to follow. Firstly, interpretation in this video conference will work very much like in a regular committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. Please speak slowly and clearly and hold your microphone in front of your mouth as directed during the sound check. If you will be speaking in both official languages, please ensure that the interpretation is listed as the language you will speak before you start. For example, if you're going to speak English, please switch to the English feed, then speak. And this allows for better sound quality for interpretation. Before speaking, please wait until I recognize you by name. For witnesses, the questioner will basically identify who they would like to respond to the questions. When you're ready to speak, click on the microphone icon to activate your mic. And should members need to request the floor outside of their designated time for questions, they should activate their mic and state that they have a point of order. A reminder that all comments by members and witnesses should be addressed through the chair. Should any technical challenges arise, please advise the chair or the clerk immediately, and the technical team will work to resolve them. And it may be necessary to suspend the meeting in such cases in order to sort things out. Before we get started, can everyone check on the upper right-hand corner of their screen if they're using a personal computer? In the top right-hand corner, there is a choice between speaker view and gallery view. Gallery view will ensure that all video participants can see one another. So I'd now like to welcome our witnesses. So each witness will have a 10 minutes for an opening statement, followed by the usual rounds of questions from members. So firstly, as an individual, we have Dr. Amir Ataran, Professor, Faculty of Law, University of Ottawa. As an individual, Dr. David Fisman, Professor of Epidemiology. I'll work on that, University of Toronto. As an individual, Dr. Richard Shebas, former Chief Medical Officer of Health for Ontario. For Blue Dot, we have Dr. Cameron Khan, Chief Executive Officer and Founder. And for Dynacare, we have Vito Ciceretto, President and Chief Executive Officer. Welcome, everyone. Thank you for joining us today. We will begin with Dr. Ataran. Welcome back, and you have 10 minutes. Please go ahead.
Thank you.
Merci. M'entendez-vous? Oui, nous vous entendons. Merci. Bon après-midi, mesdames et messieurs. Merci de m'accueillir à nouveau au Comité de la santé. J'espère que vous vous portez bien. Monsieur le Président.
Is overriding the English language.
Sorry, my mistake.
Are you on the appropriate translation channel?
I am on interpretation off. Is that correct?
No, you should be on the channel for the language you're speaking.
I'm sorry, I forgot that. Okay.
It makes a difference in terms of the sound levels for the people listening.
Okay.
Thank you.
Let's start over. Good afternoon, ladies and gentlemen. Thank you for having me back at the Health Committee. I hope you've been well and that your families have been keeping safe. When we last met, Canada was in a full lockdown, and I strove to explain how we might get out of it. I offered a roadmap for exiting the lockdown gradually. That roadmap remains valid. First, a nationwide lockdown to bring disease transmission to virtually nil. Simultaneously, a massive push to increase testing and contact tracing by a factor of 10 or more. followed by last a sequence of gradual reopenings and infection wavelets that are well calibrated by disease forecasts and monitored by testing to minimize deaths. No competent expert disagrees with this basic strategy. I said that following this roadmap would be long and difficult, and I reassured that there is light at the end of the tunnel. Sadly, some weeks on, today I'm here to tell you that the light seems dimmer than I had imagined, not for scientific reasons, but for political reasons, which you can fix. As you know, countries like Australia, Denmark, New Zealand, and Norway are executing successful reopenings. Meanwhile, Canada is flying somewhat blind because provincial and federal governments still have not solved their massive failure to cooperate in sharing and analyzing epidemiological data. Without data and analysis, many experts think reopening is arriving too early in some places like Toronto, which will kill people needlessly, and arriving too late in others like Kingston or the Maritimes after crippling the economy and ballooning the deficit. This isn't good. So my goal today is to offer a frank reality check, franker than Dr. Tam and Dr. Niemer delivered. I was saddened and frustrated that yesterday many of you asked excellent questions, but you got evasive and at times mealy-mouthed answers. So please feel free to ask me those same questions, and if I can help, I promise that I will. But first, let's start with some data. And the big question, is Canada really bending the curve? The answer is sort of. Many Canadians think that we have done well because we're better than the United States, a country having no public health care, vocal COVID-19 deniers, and a president who recommends injecting bleach. The Americans are obviously not the right comparison for us. Better that we compare Canada to other wealthy countries, especially confederations, because they have federal provincial complications like our own. So if you would please turn to the line graph that I've provided to the committee. It looks like this. I'll just hold that up for an instant. It's one of two graphs that were provided. This graph shows confirmed COVID-19 cases adjusted for population, starting on the day that a country exceeds the threshold of one COVID case per million population. Canada, the heavy black line in this graph, was the last country to face COVID-19. That's luck, and it gave us extra time to prepare and the benefit of learning from others who went before us. With those advantages, we achieved a lower infection peak. But come to the question of bending the curve down, we're doing poorly. Instead of the successful nosedive that the graph shows for France, Germany, Spain, or Switzerland, which they achieved despite a faster and higher peak than ours, our curve looks like an undulating plateau that at the end gradually drops off like a bunny ski hill. By May 18th, our daily confirmed cases were tied with April 4th. Between those dates are weeks of squandered time, lives, and money at around $12 billion a week to the macroeconomy. I find the comparison with Australia most interesting. It proves that Canada could have done better. It is a large confederation of states, much like our own provinces, and it crossed the threshold of one case per million just one day before we did. In other words, we started off tied, but instead of dithering, Australia smacked down its curve hard and fast. Its results are almost as impressive as South Korea's, which many reckon to be the world's most successful country. Now Australia is opening thoroughly, and we are not. So the costs of this failure are just massive. The next time that you hear the Prime Minister and Dr. Tam say that Canada is bending the curve, be skeptical. Be much more skeptical than you have been. Let's now talk about testing. You've heard from nearly everyone that Canada is doing a poor job and that without more, faster testing, it is impossible to reopen without unnecessarily risking and losing Canadian lives. The scientific goal is not simply testing the sick, but over-testing the vulnerable and anyone else who might have been in contact with the sick so as to isolate them for 14 days and nip outbreaks in the bud. Yet, Canada's testing remains awful, especially in Ontario and Quebec. Please turn to the bar graph I've furnished the committee. It's like this, a series of colorful bars. It shows over-testing as the ratio of total COVID tests per positive test. The higher that ratio, the better the chance of spotting infections and avoiding outbreaks. If one chooses not to worry about the price of testing, and one shouldn't, because testing costs peanuts compared to hospitalizations or lockdowns, then it is far better to test too much than to test too little. And on this measure of testing, Canada lags behind not just top performers like Australia and South Korea. We lag behind Ethiopia, Rwanda, Kenya, Cuba, and Ghana. We are such testing tightwads that low-income countries in Africa surpass us. Africans also outclass Canada on contact tracing. Addis Ababa's extensive testing and contact tracing puts Montreal and Toronto to shame. For Canada to be beaten by the world's poorest countries has got to puncture the myth of competence and success. It cannot be that Canada lacks Africa's scientists, laboratories, equipment, chemicals, any of that. No. The reason we have failed is the cupidity and stupidity of certain governments. And this is where I put my constitutional lawyer hat on to talk about federalism. American lawyers have a great saying. They say that, quote, the Constitution is not a suicide pact. But I'm afraid, ladies and gentlemen, that during a killer pandemic, our usual accepted federal-provincial relations can turn into a suicide pact. I believe that our most fundamental failing right now is that pandemic responses are handicapped by a mythological, schismatic view of federalism. Thus, when provinces withhold epidemiological data or do a poor job of testing, collectively we grumble, we shrug, and we mutter that, well, health is provincial. But this is wrong. And speaking as a constitutional lawyer, health is actually a shared federal-provincial jurisdiction. The Supreme Court is dead clear about that, and it says, quote, health is a jurisdiction shared by both the provinces and the federal government, close quote. That's our Supreme Court, and it's perfectly accurate. I think it is good for the federal government to let provinces run their show, and that's normally how it should work. But I'll suggest that a pandemic is not normal. There comes a point where the federal government must step in, the point where provincial actions are killing Canadians. If our country cannot show that once in a century flexibility, then yes, we are turning the Canadian Constitution into a suicide pact. I know that what I've just said will be outrageously controversial. I'm sorry. But as a person who loves this country, I cannot let obvious mistakes pass and kill my neighbors. So let me close with 3 recommendations. First, Parliament must pressure Cabinet into taking legal steps to force the provinces to share epidemiological data. These are the data that scientists like Dr. Fisman and Dr. Kahn absolutely need to keep you, me, and your loved ones alive as this lockdown lifts. Parliament gave Cabinet the power to demand data in Section 15 of the Public Health Agency of Canada Act. But the Prime Minister has not used that power. It's frankly pathetic. Second, demand that the Public Health Agency of Canada set minimum standards for things like testing. We cannot remain stuck behind Africa. Come on. It was only last week that the Prime Minister proposed a national testing strategy. That is much too late.
Dr. Adoran, you're at 11 minutes. Could you wrap up, please?
Sure. Third, sign an accord with the provinces on cooperating throughout this pandemic. In Australia, the Prime Minister and the Premiers signed a COVID accord on March 13th, and the Vikings have killed this thing. Those Australian Vikings have put it down. It's unbelievable that 2 months later, Canadian governments still have no COVID accord. I'll close there. I hope you take these suggestions in the spirit that they're intended, not to gore anyone's sacred cow, but to save the lives of the Canadians we love. Thank you for hearing me.
Thank you, Dr. Adoran. We go now to Dr. Fisman. Dr. Fisman, please go ahead. You have 10 minutes. Dr. Fisman, you're muted. And try to remember to hold your mic up closer to your mouth as well.
Sorry. Okay. Honorable committee members, thank you for the privilege of appearing before you. The last several months have offered us as a country extraordinary challenges. Mid-March, I have watched patients admitted to hospital with mild breathing difficulties and seen these same patients wheeled into the intensive care unit 72 hours later. My colleagues have cared for married couples and have had to tell the surviving spouse of the death of their partner while on clinical rounds. I've had the gratifying experience of watching our modeling work influence policy, and I've also experienced the annoyance of watching epidemiological data abused, misused, and distorted in support of various political, economic, and social agendas. The challenges I have faced pale next to those faced by many Canadians who have lost their jobs or lost their loved ones, often without the chance to hold hands or say goodbye. They pale next to the challenges faced by those who have worked at essential jobs under pressure from employers, but without access to adequate personal protective equipment. We've watched extraordinary leadership from senior public health officials across the country, and here I'd like to single out the clear, compassionate messaging from Drs. Henry, Henshaw, and Tam for special praise. We've also struggled with more limited leadership in other provinces, and here I would note in particular the failure of provincial public health officials in Ontario to act swiftly and courageously to stop the spread of COVID-19 in long-term care facilities, failure to clearly articulate that COVID-19 was spreading in our communities in early March, and failure to keep up with the best epidemiologic evidence on important issues like transmission of disease by individuals with few or no symptoms. So yes, we have seen many challenges, some of which we have met and some of which we have not. My group prepares forecasts for several federal and provincial colleagues each morning, and we have documented a reproduction number for the epidemic in Canada below 1 since around May the 9th, 2020. That's a hopeful sign. The reproduction number of an epidemic, the number of new cases created by an old case, is an index of epidemic growth and decline. And a sustained reproduction number below 1 suggests that this first wave of the COVID-19 pandemic is approaching an end in Canada. I have been concerned at how this encouraging turn of events has been interpreted by some to mean that this wave is ending in spite of, rather than because of, the patient selfless actions of many Canadians who've experienced hardship, isolation, and deprivation in order to distance themselves from workplaces, friends, and family. In Canada, we have seen healthcare systems stretched and challenged, but we have not witnessed the tragic overflow of intensive care units as occurred in Wuhan, in Lombardy, in New York, and Madrid. Make no mistake, our failure to experience these tragedies does not mean that models were wrong. Cities around the world that failed to react to approaching epidemics as promptly as Canadian cities did have experienced astounding surges in mortality. A 300% increase in death in New York, 75% in Stockholm, 460% in Bergamo, 100% increase in mortality in London. We reacted to approaching disaster in time to avert the worst of this first wave, though in our two largest cities, Montreal and Toronto, we still have several hundred individuals in intensive care units. And now we face what I'll refer to as the paradox of prevention. By preventing widespread infection in the country, we've maintained susceptibility in the population, which leaves us vulnerable to future waves, future epidemic waves. This is the defining paradox of public health. Our fundamental deliverable is the non-occurrence of events. To those of us who work in the field, we're accustomed to having our outputs taken for granted. To note one familiar example, vaccination programs are criticized because their very success means we don't experience outbreaks. Perhaps a silver lining to this episode moving forward will be a greater appreciation of what public health provides us in normal times. But back to our successful avoidance of even greater tragedy in Canada in March and April. Having achieved this important success, we need to move forward with economic revitalization. And I think presentation of our choices as economic revitalization versus prevention of disease transmission is a Hobson's choice or a false dichotomy. We can't ignore our economy, but we won't have robust revitalization without strong surveillance systems and health protection measures. A frightened and grieving population will not drive a strong economy. In the United States, data assembled by JP Morgan Chase show clearly that declines in spending are strongly linked to levels of disease activity. The bedrock on which revitalization rests will be public health surveillance and laboratory testing. We can't see this epidemic without testing, and we can't fight an epidemic that we cannot see. The virus is a slippery foe, and it's a study in contradictions. I call it Schrodinger's coronavirus. It's dangerous and it's lethal, but it causes mild illness and even infection without symptoms. It kills over 7% of the Canadians with recognized infection, but it gives most children a free pass. Asymptomatic and pre-symptomatic infections are a Trojan horse, which gives entry to congregate settings like long-term care and retirement homes, healthcare facilities, prisons, and food processing plants. Once it's spreading in these institutions, it can take a terrible toll, as we have seen in long-term care facilities. We can look around the world for successful responses to this epidemic and emulate best practices, but we can also emulate best practices here in our own country. Colleagues in Newfoundland have controlled COVID-19 rapidly. They tell us to hunt the virus and be proactive. Colleagues in British Columbia teach us how important clear strategy and communication are in this fight. Alberta can show us how to scale up testing, and our northern territories show us how to protect isolated remote communities. Saskatchewan has shown us how to deal swiftly with growing outbreaks to prevent geographic spread of infection. But I do believe that our most potent weapon in the fight is testing. Work by my colleague, Dr. Ashley Chute, shows that without aggressive testing, control measures like contact tracing are likely to be fruitless, as we will only perform contact tracing on tested cases. If we fail to test at scale, we will miss too many additional cases for contact tracing to change the dynamics of the epidemic. It'll simply be a waste of resources. If we test at scale, we can keep the epidemic in our sight and move towards economic revitalization while keeping Canadians safe. Testing will be our eyes and ears as we move forward to open our economy, but the laboratory is a tool that needs to be used differently in different settings. We need to establish regular testing regimens for those who work in congregate settings with vulnerable individuals, especially in long-term care and in hospitals. Testing in a stable and consistent way allows us to estimate the reproduction number of the epidemic and know when we're headed back into exponential growth. We want to find all the cases we can. That's how we prevent sparks from turning into forest fires. Hospitalizations and deaths are easy to see, but they're lagging indicators. Instituting control policies once they are surging means we've already missed the boat. We can use non-traditional surveillance tools too, like web-based syndromic surveillance and even surveillance of sewage for coronavirus levels, as is already being done in other countries. Situational awareness will keep us safe as our economy comes back to life. We can also demand more of our country. This epidemic shows us that having laboratories with 21st century diagnostic technology, but public health information systems that depend on fax machines from 1995 will hold us back. We can demand more transparency from our leaders. As action by the public is central to disease control, It's important that the public be kept in the loop and made to feel like they're on the team. Indeed, they are the team. We need clear, transparent benchmarks across the country on testing, on turnaround times for case reporting and contact tracing, and for the reproduction numbers that will be used to determine when we need to strengthen distancing and when we can loosen it. We will have more setbacks. The countries with the strongest response programs in the world have all suffered them. We will too. I'd ask you not to throw up your hands and let the virus win. Don't let uncertainty distract you from the mission. Uncertainty is to be expected for a disease that's been in humans for 24 weeks. Don't let smug professors bully you about the absence of randomized controlled trial evidence for control of a disease that's only existed for half a year. We can acknowledge uncertainty and be humble about this disease, but always put the lives and livelihoods of Canadians at the forefront when we make our decisions. Thank you for the opportunity to answer your questions today.
Thank you, Dr. Fisman. We go now to Dr. Shebas. Please go ahead. You have 10 minutes, please.
Mr. Chair and members of the committee, it's a privilege to speak with you today. I'm a retired physician. I practiced medicine for 40 years in two specialties, public health and internal medicine. I worked in local public health for 15 years. I was Ontario's Chief Medical Officer of Health for 10 years, and I was directly involved in the 2003 SARS outbreak as Chief of Staff of York Central Hospital. I published academic and popular articles on relevant subjects like SARS, quarantine, and bird flu. Canadians on the whole enjoy a wonderful standard of health, resting on the foundation of the social determinants of health, education, employment, and our social fabric. Anything that threatens these foundations threatens our public health. Canada is now faced with both a tragedy and a crisis. The tragedy is caused by COVID, a respiratory virus. Its potential to cause deaths of tens of thousands of Canadians, it has the potential to cause the death of tens of thousands of Canadians, overwhelmingly old and infirm. The crisis is caused by our attempts to control that virus. The crisis has the potential to cause severe and lasting damage to the fabric of our country's economy, education, social and cultural institutions, and mental health that will have repercussions on our public health for decades. The tragedy is a natural disaster that saddens me and saddens us all. The crisis is a self-inflicted wound that frankly terrifies me. It offends social justice because the burden of the crisis falls disproportionately on children, young families, and blue-collar workers. The more we focus exclusively on COVID, the greater the danger to our public health. The best analogy to the COVID outbreak is the H2N2 Asian flu pandemic that swept around the world in the fall of 1957. Asian flu caused more disease at a much higher death rate, especially in younger people, than COVID. Asian flu killed between 1 and 2 million people in a matter of a few months in a world population 1/3 the size of today. That's the equivalent of 3 to 6 million deaths today, many more times than COVID. Asian flu was a tragedy, but it wasn't a crisis because 60 years ago, people responded differently. Some modest control measures were taken, but they were very temporary. The world moved on. Perspective isn't very popular with COVID, but I think it's important. We get spooked by COVID deaths because every day we see the numbers for COVID, but not for anything else. Death is a common phenomenon in our world. Almost 300,000 Canadians will die this year, like every year, from cancer, heart disease, stroke, motor vehicle crashes, suicide, and a myriad of other causes. Since mid-March, for every Canadian outside of long-term care who has died of COVID, 50 Canadians have died from something else. We have frightened people. Predictably, the media has led the way, but public health has also frightened people, I think, to promote better compliance with social distancing. This was wrong for two reasons. First of all, because it's cynical. And secondly, because it now will make it that much harder to step down. My wife and I live in Toronto, and we walk our dog. And when we walk our dog, we see two kinds of people. Those like us who've done the math and aren't really very frightened by COVID, and those who think walking the streets is dangerous. But there's a third group, the people in our building who we haven't seen for 2 months, who are too terrified to even go outside. Getting them to re-enter the world will be a tremendous. Only reliable defense against a respiratory virus is immunity. You can get immunity from being infected, or you can get it from a vaccine. A safe and effective vaccine would be wonderful, but it would be foolish to build public policy around expectations of a vaccine anytime soon. Any strategy that doesn't take us towards immunity ultimately leads us nowhere. So long as the disease is circulating elsewhere, it's coming back here too. Provincial or national elimination is a false promise. Population immunity leading to herd immunity is a natural phenomenon, not an intervention, not an experiment. Herd immunity is what has controlled every other respiratory virus. We will get there sooner or later with COVID. The policy challenge is to mitigate the worst effects of the disease while protecting the real determinants of our health: education, employment, and our social fabric. We have better information about COVID than we did 2 months ago. We know that COVID is very serious, certainly much more serious than I, for one, expected, but it's also not the apocalypse that some of the models have predicted. Not even remotely close. The comparison should be with 1957, not 1918. We know that our healthcare system can cope. A combination of expanded capacity, better treatment strategies, and triage mean that the apparent capacity crisis in Italy has not been repeated here or really anywhere else. We know that the great majority of people in Canada are at very little personal risk of death from COVID. For virtually everyone under the age of 60, and for people without serious comorbidities to a much older age, the risk of death from COVID infection is not materially different than the risk of dying from influenza. We are two populations: the frail elderly for whom COVID is a deadly disease, and the great majority for whom it is not. Canada's experience in the last 2 months has been problematic. We seem to have been reasonably effective at reducing infection in the community, but we have not been effective in protecting the institutionalized frail elderly because of a massive failure of infection control in some facilities. As a consequence, we have had many deaths, but have relatively little population immunity. The COVID outbreak in the Northern Hemisphere has been on the wane since late March, for almost 2 months. The policy tide worldwide is now towards reopening, and Canada will be swept along. My real concern is that the virus will return, probably in September, and that our attempts to control it with widespread testing and contact tracing will probably fail. I've worked long enough in public health to understand the limitations of contact tracing as a disease control strategy, particularly for a disease like COVID. But when this strategy fails, will we panic and lock down again, this time indefinitely? Or will we respond in a more measured and rational way? We have some time now to prepare. If Plan A is based on testing and contact tracing, we need a Plan B. What should we do now? We need to identify those things that are fundamentally non-negotiable. Education, which requires reopening the schools, and employment, which requires for many people returning physically to work, should be top of the list, along with access to medical and dental care. Second, we need to be clear that we are pursuing a policy of mitigation, not elimination. With mitigation, we can tolerate an increase in cases when we open up now and again when the disease resurges in the fall. We will regard community spread as inevitable and a step towards population immunity.
third, we need to do serious policy work to identify those aspects of social distancing that are effective, acceptable, and sustainable. Canada's latest fad is for non-medical masks, based on the thinnest of evidence. Let's think carefully before we change ourselves into a society that hides its face in public. Fourth, we must develop better strategies to protect the vulnerable and particularly better infection control in long-term care institutions. This alone will go a long way towards reducing mortality. Fifth, we need to change our messaging to the public to better reflect their real risk of serious illness and death so that people will be willing to come out of isolation and resume normal life. Sixth, we need to look for ways to develop public health policy nationally. We need a national, not a federal, public health agency that engages the provinces with the federal government as equal partners. Thank you.
Thank you, Dr. Chabas. We go now to Dr. Khan. Go ahead with Blue Dot. Go ahead, Doctor. You have 10 minutes.
Okay, thank you. Can you hear me okay?
Yes.
All right, perfect. Hey, good afternoon, ladies and gentlemen, and thank you for inviting me to be a part of this important discussion today. First, let me introduce myself and tell you a little bit about my background and its relevance to today's meeting. My name is Cameron Khan, and I'm a physician trained in internal medicine, infectious diseases, and preventive medicine and public health. I practice medicine and am an epidemiologist who's been studying outbreaks of emerging infectious diseases at St. Michael's Hospital in Toronto for the past 17 years. I'm a professor of medicine and public health at the University of Toronto and am the founder and CEO of a digital health company called Blue Dot. So what has motivated me to dedicate my professional life as a clinician, an academic, and an entrepreneur to the field of emerging infectious diseases? Well, 20 years ago, I began my training in infectious diseases and public health in New York when West Nile virus arrived in the city and began its westward march across the continent. 2 years later, shortly after the terrorist attacks of September 11, 2001, anthrax was weaponized and dispersed through the US postal system, reminding us that deadly outbreaks can arise from deliberate acts. After returning to my home in Toronto, 2 years later, a coronavirus known as SARS spread from mainland China to dozens of cities and countries around the world, including Toronto, where it triggered a deadly outbreak that lasted 4 very long months. And while the world has never seen an outbreak quite like SARS before, it was clear that this wouldn't be the last time. Now, the world is changing in ways that are driving the emergence and spread of dangerous diseases, but it's also changing in other ways that can play to our advantage. The rise of big data, the advent of artificial intelligence, and emerging digital technologies offer us the raw materials needed to literally spread knowledge around the world faster than any outbreak. This was the inspiration for Blue Dot's founding 6.5 years ago, to build a digital global early warning system for infectious diseases that can transform how the world prepares for and responds to tomorrow's inevitable infectious disease threats, whether they arise from Mother Nature, accidents, or deliberate acts. The early warning system that we have developed at Blue Dot serves 3 key objectives. First, to detect infectious disease threats as early as possible to buy ourselves valuable time. Second, to assess their potential for global spread and impact so that we can channel our finite resources to the right place at the right moment. And third, to empower a wide array of decision makers from government to healthcare to the private sector with timely insights so that together we can mobilize highly effective, efficient, and coordinated responses. To detect threats at their earliest stages, our early warning system processes vast amounts of online data in 65 languages, searching for early signals of outbreaks involving over 150 different diseases and syndromes, 24 hours a day, 365 days a year. This surveillance engine does not rely solely on official news of outbreaks reported by government agencies, but also analyzes unofficial information generated through digital media, health blogs, and other online sources. This engine picked up an article in Chinese on the morning of December 31st, 2019, reporting on an outbreak of pneumonia of an unknown cause in Wuhan, China. This event certainly captured my attention given the number of parallels to the emergence of SARS in 2003. Within a few seconds of detecting the outbreak in Wuhan, our system analyzed the flight schedules and anonymous itineraries of hundreds of thousands of travelers departing Wuhan on commercial flights for destinations around the world. Given our early concerns about this outbreak, my team submitted results of this analysis for publication in an open access peer-reviewed scientific journal on January 8th, 2020, in order to make these data freely available for anyone to access. This analysis accurately identified many of the cities outside of mainland China that were among the first to confirm cases of COVID-19. As cases of COVID-19 arrived in North America, our team began generating insights to support public health efforts to mitigate domestic transmission of this virus within our communities. These analyses made use of anonymous location data generated from mobile apps to understand the movements of populations, critical insights for public health officials to optimize and strategically make use of their finite human resources across the country and over time. It's worth noting that Blue Dot only makes use of third-party data that is anonymized, adheres to all legal and regulatory requirements, and is aggregated up to the level of populations. These location data have been used for years in sectors from urban planning to transportation to retail, among others. Here, we are making use of them for the sole purpose of safeguarding communities and protecting lives during the midst of a pandemic. At Blue Dot, our diverse team comprised of physicians, veterinarians, epidemiologists, geographers, ecologists, data scientists, and engineers have been diligently working for the past 6.5 years, leveraging data, advanced analytics, and emerging digital technologies to develop innovative solutions that are capable of generating insights to mitigate risk from infectious disease threats in our rapidly changing world. But insights are only meaningful if they are translated into action, and that translation can only happen through partnerships. In this regard, Blue Dot has had a long-standing partnership with Global Affairs Canada, going back to 2014, where we have been building and implementing digital systems to manage infectious disease risks across the Association of Southeast Asian Nations. And in 2019, we began a partnership with the Public Health Agency of Canada, channeling our efforts to mitigating domestic risks from global infectious diseases. And now, as the COVID-19 pandemic evolves into new phases, we continue to work together to mitigate its impacts across the country. I'd like to conclude by saying that Mother Nature is sending us a message. A confluence of forces in our rapidly changing world, population growth, urbanization, the industrialization of agriculture, the disruption of wildlife ecosystems, climate changes, and increases in global population mobility are accelerating the emergence and global spread of infectious diseases with unprecedented consequences. As global citizens, this is a reality we have to confront, or we risk finding ourselves in the same precarious position we are in today a few years down the road. We've also learned that outbreaks in our hyper-connected world move incredibly fast. If we want to remain a step ahead, we're going to have to move even faster. Thankfully, we have what is needed to generate powerful insights, access to diverse and novel data, and human intelligence coupled with artificial intelligence to drive meaning from these complex data. But we also need to translate insights into actions that reach across the whole of society. Governments empowered with timely insights will be better able to protect their citizens and economies from dangerous global infectious diseases. Hospitals and healthcare providers will be better able to protect themselves and the rest of us from the very same diseases. And businesses will be better able to protect the lives and livelihoods of their employees and customers. Creating an ecosystem to manage these risks together is not only possible, but in my opinion, necessary. A final thought to leave with you. Our most valuable resource is time, and it is a non-renewable resource. When we get through COVID-19, and we will, the question for all of us will be whether we use every day of peacetime to prepare for the next inevitable threat with the same sense of urgency with which we are responding to COVID-19 today. Thank you for the opportunity to share my thoughts with this committee.
Thank you, Dr. Khan. We go now to Mr. Ciceretto, President and Chief Officer of Dynacare. Go ahead, please. You have 10 minutes.
Thank you. Good afternoon, and thank you, Mr. Chair and members of the House of Commons Standing Committee on Health for your invitation to this very, very important meeting. I hope that each of you and your families are healthy and well. It is a privilege to be with you today on behalf of Dynacare to discuss the Canadian response to the COVID-19 pandemic. At Dynacare, we believe that life is precious. Our mission is to support the health of Canadians with commitment and care. That is why we do what we do. Our 2,900 DynaCare employees deliver the highest level of clinical and scientific testing to provide the necessary information that supports the diagnosis, treatment, and well-being of Canadians. Each and every day, we provide testing and medical laboratory services to over 32,000 Canadians across the country, amounting to over 11 million tests annually. We operate 200 convenient and accessible specimen collection centers in Ontario, Manitoba, and Quebec. We operate 7 state-of-the-art laboratories in 4 Canadian provinces. We report over 500 critical results requiring immediate action by physicians. Our goal is to inspire confidence in Canadians when it comes to managing their health and well-being. To achieve this, we have elevated the patient experience at our specimen collection centers. We continuously innovate by introducing new and improved test methodologies such as genetic testing, liquid-based cytology, non-invasive prenatal testing, and the piloting of Pixel, a self-collection test methodology utilized in remote rural communities. We've introduced patient-friendly diagnostic testing reports and digital apps that help Canadians better manage their health journeys. This unprecedented pandemic has highlighted the fact that the work we do at DynaCare matters now more than ever. We are very proud to play a critically important role in supporting the provincial public health authorities of Ontario, Manitoba, and Quebec in their efforts to control this pandemic. Since March 25th, our talented scientific and laboratory professionals at DynaCare have conducted over 40,000 COVID-19 molecular tests across these provinces, including COVID-19 testing for members of vulnerable and priority populations, such as those in emergency shelter systems, residents of long-term care facilities, EMS first responders, and healthcare workers. Even throughout this pandemic, DynaCare has continued to operate its laboratories and accept patients at our collection sites for urgent non-COVID-19 testing. In addition to the provision of COVID-19 testing, our community laboratory infrastructure has helped to alleviate pressure on provincial public health systems and hospitals. In particular, our medical couriers have quickly and safely transported COVID-19 test specimens from screening and assessment centers to DynaCare, public health, and hospital laboratories. On behalf of the provincial public health labs, we have delivered negative COVID-19 test results to over 25,000 patients. We have supported vulnerable populations by establishing designated DynaCare specimen collection sites for immunocompromised patients and for COVID-19 positive patients. We have engaged in non-COVID-19 sample collection at long-term care facilities. Our employees have rallied behind DynaCare's response to this pandemic, and as such, we celebrate the many acts of compassion through our DynaCare Healthcare Heroes social media campaigns. Our people are the ones that have truly stepped up. The COVID-19 testing system has generally been working well with strong collaboration between public health agencies, community laboratories, and hospitals. But as with any unprecedented and rapidly evolving environment, there are challenges and opportunities for improvement. The technical nature of the nasopharyngeal collection process, along with the required swabs, which are employed in the collection of a COVID-19 sample, have been rate limiters in terms of testing and have increased the demand for PPE. DynaCare has over 850 phlebotomists at over 200 collection centers who are not authorized to collect samples using the current collection devices. By employing alternative specimen collection procedures used in other countries, our team can support provincial screening. To this end, DynaCare is embarking on a study with Sunnybrook Occupational Health to validate alternative sample collection methods using saliva and front of nose collected specimens. The results of this study are expected within a few weeks. Secondly, shortages of testing reagents and collection kits were common early in this pandemic. Due to increased vendor production and the proactive response of our supply chain team, we appear to have sufficient supply for our current volume of testing. However, in order to support expanded testing needs, our intention is to increase testing capacity, both through new collection techniques and through supply chain preparedness. Global demand has made it very difficult to secure additional testing capacity and reagent supply on a timely basis. Vendor allocation practices drive more test capacity and reagent to jurisdictions that have been more severely impacted by the COVID-19 virus than Canada. It's important to everyone at Dynacare that at the end of every laboratory test that we perform, there's a person, a mom, a dad, a daughter, a friend. It is not uncommon for our dedicated teams of employees to go above and beyond the call of duty by helping to secure a replacement test requisition for a patient, by leading a drive-by convoy to acknowledge the efforts of frontline healthcare workers at hospitals, or by making extended efforts to contact a patient with a critical the value our dedicated employees bring to the healthcare system, and as such, we go to great lengths to take care of them. Notwithstanding the significant drop in non-COVID-19 test volumes during this pandemic, we have not thus far implemented furloughs, layoffs, or reductions in base pay due to our long-term philosophy and government wage programs. We are very proud of this and believe that it positions us well for the future. As doctors' offices and clinics reopen, as elective surgeries start again, and as insurers and employers resume regular activities, Dynacare will be in a position to meet the laboratory testing needs of our patients and clients and support our health systems across Canada. Unquestionably, our workplace will be defined by a new normal, with new social distancing and PPE protocols that will protect our patients and our people. As the number of patients requiring service continues to increase, these new protocols will demand the need to adapt, and we will. Across Canada, some provinces are slowly beginning to open back up in ways that we would not characterize as business as usual. In the absence of a vaccine and lack of scientific consensus on the potential for immunity to the COVID-19 virus, some employers are expressing concern that their workplaces could be prone to COVID-19 outbreaks. Employers across a number of sectors, including food and beverage production, natural resources, manufacturing, and many more, have expressed an interest in the provision of COVID-19 testing at their own cost. Dynacare's priority will always be supporting health systems in responding to the emergency presented by COVID-19. As the economy opens up, we see a need to work with industry to avoid workplace outbreaks as a means to limiting the community spread of COVID-19. Key to restarting the Canadian economy is high-quality antibody testing, which can determine whether an individual has been exposed to the COVID-19 virus. Public health authorities, in conjunction with medical and scientific experts, are working to determine how COVID-19 antibody testing could be applied. This past week, 2 COVID-19 antibody tests were approved by Health Canada. Dynacare is currently working with 2 additional vendors that will be seeking Health Canada approval for an antibody test. Community laboratories like Dynacare are very well positioned to support large-scale provincial COVID-19 antibody testing surveillance programs through its extensive specimen collection network of 200 centers, our well-equipped laboratory facilities, and our extensive logistics network. We do this every day, efficiently, effectively, and with compassion. In public health emergencies, those in poor health or with underlying chronic conditions are often the most vulnerable. For many, the COVID-19 pandemic has emphasized the importance of keeping Canadians healthy and decreasing the prevalence of chronic conditions such as cardiovascular disease, lung disease, metabolic syndrome, and diabetes. At Dynacare, we believe that life is precious, and we look forward to continuing to improve the health of Canadians by providing ongoing support to provincial healthcare systems and through health and well-being programs at Canadian Workplace. both through the COVID-19 pandemic and beyond. Thank you again for the opportunity to address this committee. Take care and be well.
Thank you, Mr. Ciceredo. We'll start our rounds of questioning now. We will do 3 rounds. We will start the first round with Ms. Jansen. Ms. Jansen, please go ahead. You have 6 minutes.
Yes, thank you to everybody for all their presentations. That was very, wholesome. That was great. I'd like to actually start with Professor Adoran. I really found your written submission, very interesting. And I had to chuckle when you pointed out the fact that some hospitals are still faxing in their data. My first foray into state-of-the-art technology on the farm here was when we bought a fax machine back in 1992. It's 28 years ago. But however, in order to stay in business, we obviously had to invest in better and better data collecting technology. And I have to say, I was completely shocked to find out from previous witness testimony at this committee that our healthcare system doesn't have a real-time data collection system in place, especially considering the different recommendations that have been made following previous pandemics. Now, we've had several witnesses come to this committee and beg us to find a way to move forward with a pan-Canadian data collection system that works in real time. A system like this could help us on so many different levels, not just during a pandemic. But it seems that there's this fear that sharing information in this way will compromise the autonomy of provincial and local health authorities. In your opinion, is there not a way to ensure that each provincial and regional jurisdiction can continue to make decisions that make sense for them while still sharing their data and helping the country with a more informed pandemic response?
What a great question. Thank you. Look, the question of sharing epidemiological data, it's about like this. If you had a number of people who had pieces of a map of a minefield, would you tolerate them not sharing that data? I think you'd probably want to know a map of the entire minefield, not just your little patch of it, if you were setting out on a journey. The current situation is as foolish as that. Each province has a certain amount of data about the outbreak within its borders, and it can either contribute that piece to modeling exercises or not. And depending on whether it does so or not, we have a better or worse view of the epidemic. I think the answer to your question lies in a legal part as well as an administrative part. Legally, it's very simple. Cabinet just needs to use Section 15 of the Public Health Agency of Canada Act and issue an order in council that data must be provided, period. Parliament gave it that power. It simply leaves me speechless that the current cabinet hasn't used it. So that's something I hope you follow up with.
Okay.
And
Sorry, I have a really short amount of time, so
I'm sorry.
Okay, I appreciate that. You mentioned in your submission, obviously, the dysfunction that we have in sharing data. And again, being from a business background, I've worked in the retail sector for many years, and our spring system was always very short. We did like 8-week period across multiple provinces. And so that meant timely data was absolutely critical to make these decisions of where to send product and when. We're able to take into consideration those regional differences to ensure the right assets are sent to the right place at just the right time. And we know the technology is available for a pan-Canadian data system. Yesterday, Dr. Tam mentioned that PHAC has no choice, and now you're mentioning that actually they do under the Section 15. So it strikes me, if StatsCan is able to aggregate information about Canadians without violating privacy rights, surely the healthcare system can do the same.
And StatsCan can do the same. They could build this system inside of about a couple of weeks, I'm told. But they need the mandate from Cabinet, and that's what's missing.
Okay.
There you go. I'll just add one last thing to this. There was a time in this country when the federal government did provide a contract to somebody to develop such an epidemic data reporting system. It was given to IBM Canada. The system did not function, and they're the same ones who are behind Phoenix. So there's not a good history here.
Okay, thank you. So I have another question. I've asked numerous witnesses if they would give PHAC a grade on their pandemic response so far, and so far no one's been willing to give me a straight answer. I've actually been hearing of some backlash by PHAC to those who are vocally critical in their response of the pandemic. So are you willing to give me a grade, or could that disadvantage you in your work in some way?
Look, my grade is a C- or a D. And there is retaliation, yes. I mean, since the last time I appeared in front of this committee and I was negative about some of those efforts, I was asked to join a grant application with people from PHAC, and I understand that they said they wouldn't participate unless I stood off of it, which I did willingly because I didn't want to cause trouble for my colleagues. But I don't feel that there should be retaliation against witnesses simply for providing our democratic government what we think is the truth.
Oh, okay. Then thank you for that direct question or answer. I appreciate that. Yesterday, Dr. Niemer talked about the task forces which she set up to tackle the Canadian pandemic response. She mentioned that although she could share the agendas, she couldn't share the deliberations or findings because they're secret. And I believe there are other countries around the world who have set up similar task forces that are sharing their research papers publicly, which help us all. Do you think that the findings of these task forces should also be public so we can have that timely data sharing for better pandemic response?
I can't even believe that's a question. Of course, it has to be public. Science is conducted in public, always. And if you look at a country like Switzerland, they too have a task force on COVID, a scientific task force. If you go to the website, there are over 24 public reports by that task force published. If Switzerland, little Switzerland, can get 24 reports out of their task force by now, why does Canada have 0? It's shameful.
Thank you, Ms. Jensen. We go now to Mr. Fisher. Mr. Fisher, please go ahead. You have 6 minutes. Mr. Fisher, you're muted.
There we go. Thank you, Mr. Chair. Dr. Fissman, you have a wealth of experience in the battle against infectious diseases. Yet you've publicly explained that predictions that you made earlier this year on the virus were wrong. I think we can both agree that hindsight is 20/20, and there's been a lot of discussion at this committee about why certain decisions were made in the early days of this virus. I wonder if you could explain to this committee and to Canadians about the difficulties of making predictions around a novel virus and why what's considered the best advice one day can change and evolve so quickly the next.
I think part of the difficulty relates to the fact that viruses are the troublemakers, and I think Dr. Khan alluded to this. The troublemakers tend to be RNA viruses. That's the genetic material that come from animals, and RNA viruses are very good at mutating. And what we see with this virus, which is a cousin of SARS-1 and bears a lot of genetic similarity to SARS-1, is that it behaves differently in important ways. So being 80% similar can still translate into some very important differences, but some very important similarities. What we tend to see, what we almost always see with infectious diseases as they emerge, is we find out about hotspots first. So typically what we have is this sense of the virus being more virulent than it ultimately turns out to be. That's certainly been the case with some outbreaks. What we saw with this virus also initially was it looked a lot like SARS based on the information we knew from China. I know I've acknowledged this publicly that I think my biggest mistake was thinking it really was looking like SARS in China. We did some forecasting on how the Chinese seemed to be doing in terms of controlling it, and we accurately forecast that it would be done in Wuhan by early March, and that was right. The difficulty was that we didn't see Iran coming. And once you saw this in Iran, you sort of knew the game was over, and you knew that this was going to disseminate around the world.
Pardon me, Dr. Fitzman, could you hold your mic up, please?
Oh, I apologize. I'm new to this. So you know, they're all the same, but they're all different. And when you look at some of the key parameters as we talk about them with these diseases that let you sort of predict how things are going to play out, some important numbers are the reproduction number of the disease, the number of new cases per old case. This virus turns out to be a real trickster in that it's got what's called an over-distributed reproduction number, where many cases are dead ends, but some individual cases make 40 secondary cases. And you see that play out again and again, whether it's in nursing homes, on cruise ships, in restaurants. There's a single individual in Korea who infected 40 secondary cases and sparked a massive outbreak in the city of Daegu. So that makes it difficult. It also provides, perhaps we'll talk about this, it also provides a potential vulnerability for the virus in terms of control, because once you get rid of those large gatherings that make super spreading events difficult, the virus becomes much less transmissible. The initial case fatality that we saw coming out of China, that's deaths per case, was listed as 2.4%. Of course, deaths go up slowly with this thing because people die in the ICU. So the China case fatality, I think at this point is 5-6%. We're at 7% in Canada. What we know now, and we've been helped a lot in this regard by data from Spain from last week, from a national seroprevalence study, where they're able to find both the recognized and the unrecognized infections, is about 5% of the country of Spain has had this, with 27,000 deaths. So now we're able to go from a case fatality in Spain, which is deaths per recognized case, down to an infection fatality rate, which from Spain we now are pretty sure is about 1.2% based on seroprevalence data. The fact that Spain is at 5% prevalence, 30,000 deaths in, infection fatality rate of 1% makes me very concerned about some of Dr. Shabas's remarks in terms of moving towards herd immunity. We think we'd hit herd immunity at 60-70% of Canadians infected. 70% of Canadians infected is 28 million people. 1% of that is 280,000 Canadian dead. I would note that the failure to have mass mortality in Canada to date relates to the public health response. I would also note that we can do this because we've shown around the country that we can control this disease without just letting it rip and pushing for herd immunity as they're doing in Sweden. We've seen competence in British Columbia. We've seen tremendous competence in Atlantic Canada and on the prairies. We can do this. We just need to get the job done. So throwing your hands up and saying we're going to follow Stockholm, Sweden, which is currently leading Europe in per capita mortality, is not the way to go, in my opinion.
Thank you. I had other questions for you, and I think we've run out the clock, but I do want to say that is excellent, very thoughtful testimony. I want to thank you for that, Doctor.
Thank you.
Thank you, Mr. Fisher.
Mr. Chair, I have a point of order.
Go ahead.
Thank you. I'm still somewhat shocked at the evidence I heard from Dr. Ataran about him potentially being discriminated against or have retribution threatened against him as a result of his testimony before the Health Committee. All of us as members of this committee have an interest in upholding the integrity of this committee and to ensure that all witnesses who come before us can give us a sincere, unvarnished benefit of their opinion, particularly when we're talking about science. So I would like to ask that this committee formally request Dr. Ataran to indicate to us full details of what has occurred by PHAC or Stats Canada or whoever it was to ensure that the integrity of this committee is upheld at all times.
Thank you, Mr. Davies. Under our current operating mandate, we don't have the authority to do that. We can certainly invite him to submit all of the evidence, all of the allegations that he has to us or to the Speaker of the House. But we would be unable to deal with a matter of this kind in our current operating situation.
Mr. Chair, if I might. I would vehemently disagree with that. This committee is mandated to receive evidence. clearly in the consent order of the House of Commons. If we have evidence before us that witnesses are being pressured or intimidated against not giving evidence, that is a direct interference with the precise mandate of this committee. And so on the record, I'm happy to ask Dr. Ataran to provide those details, but for the record, I want to say in the strongest terms possible that it is absolutely the prerogative and mandate of this committee to ensure that we uphold the integrity of our process. And anytime we hear that a witness may have been intimidated or harmed in any way for simply accepting the invitation by us to come give us the benefit of their testimony is absolutely part of this pith and substance of this committee. And I will pursue this matter fully if once we get that information from Dr. Ataran.
Thank you, Mr. Davies. Your point is well taken. I will take the matter under advisement. And
Mr. Chair, I have a point of order.
Here.
Mr. Chair, point of order.
Dr. Kitchen, go ahead.
Mr. Chair, this is, I'm 100% behind what Mr. Davies said, but my point of order extends further than that, to which the point is we as committee members are here to present and ask questions to protect our witnesses as well as to protect ourselves and make certain that we have that protection. If we do not have that as a committee, for us, the questions and points that we may bring up can be held against us, then that's just not acceptable. And how can we function as a committee if that's not the place?
Mr. Chair, it's Matt. Just to add on to that, if you could point us in some direction as to why you don't think we have these powers to be able to do that, this committee. I disagree with you. I agree with Mr. Davies that it's within the mandate of this committee to ask for that testimony. So if you can point us in that direction, please do. If you can't, then I suggest we allow Mr. Davies to proceed on his point of order.
Your points are well taken. It should be pointed out that all testimony before this committee, when it's operating in an official capacity, is privileged. We have parliamentary privilege. Any repercussions that fall from that, it would be a serious matter. But our mandate is solely to receive evidence, and we are explicitly allowed to do motions relating to to inviting and scheduling witnesses. We do not have the authority at this time to undertake a motion to demand information about a matter such as this. But I certainly will welcome Dr. Ataran's information if she provides it. I wonder if our clerk would like to give an opinion on this.
Monsieur le Président.
Mr. Chairman, if I may. Just a point of order. I think that Dr. Ataran. Yes, Mr. Chairman, this is Mr. Thériault here. On a point of order, Mr. Chairman, this is Mr. Thériault. Dr. Ataran seems to be wanting to make some remark, and perhaps it'll clarify exactly what it is that he is concerned about, and perhaps at that point you might be better able to respond. So I'd like Dr. Ataran to be able to say what he has to say. He raised his hand. I saw that on my screen, so I'd be grateful to you if we could hear from the doctor right now before we deliberate any further on the matter.
Witnesses aren't able to participate in the committee in points of order, but I certainly, as said, I will welcome his information. I invite him to bring it to the committee, to send it to committee. The clerk will be looking into this matter and will come back to us at a later time with an opinion. And in the interim, I will reserve judgment and suggest we carry on with the testimony. So, Mr. Thériault, please go ahead. You have 6 minutes.
Thank you, Mr. Chair. I'd like to ask my question of Dr. Ataran first. Now, it would seem that all decisions are made in the name of science nowadays, and science is almost God. And sometimes it strikes me that science is used to support political politicking. And on page 3 of your brief, you referred to what the Prime Minister said about the closure of the borders in halting or containing the disease, that would be ineffective. And that is what the health officer said. Some people hold that opinion. Now, it's my understanding that you disagree with any danger about closing the border. And when the US-Canada border was closed, we apprised of all the information that we really needed. And what information would we have needed to make a swifter decision? And what do you make of these contradictory scientific opinions on the matter, moreover?
Merci, monsieur. Vous avez raison.
You're right, sir. Often scientific issues are politicized at the same time. And that was the case with the closure of the US-Canada border. I think that the closure of the US-Canada border, particularly, that decision was intended to protect us. But you are, I'm sure, aware that the World Health Organization has said that closing borders is next to useless. And I don't agree with that. I know that when we get through the current disaster, and we'll rethink this situation. Now, if you look at Africa, for example, in Africa, the borders between countries in Africa were closed very quickly. They decided to do that because of what they saw with the Ebola outbreak. And now we see that the countries in Africa are better protected, and the infection rate is far less than it is in Kenya or Rwanda than what one would otherwise think. So it means that it works, shutting a border, doesn't it? Question. Some witnesses have insinuated that it was important not to get behind the 8 ball when it came to this virus. And often the incubation period is approximately a fortnight, 14 days. But we've been getting the sense that we're playing a game of catch-up since this epidemic broke. And I imagine that we should have acted much more quickly in our decision-making, and that would have been much better. You referred to structural, systemic problems with the Canadian Confederation, and that in a sense it straitjackets public health authorities and scientists and prevents them from working in tandem cooperatively when it comes especially to sharing scientific data. But what's the point? Why not have more cooperation? You used Ontario as an example and its response to SARS. So what would be the interest of any province, whether it be Quebec or any other province, to not cooperate in that manner? I really have trouble wrapping my head around that.
Moi, je ne comprends pas.
Response. Well, I just don't get it either. It's tantamount to being dangerous to, in the Canadian Federation with 10 provinces, that we can't agree on issues of science and medicine, specifically this virus that we're experiencing right now. You're right, sir, you're right. Question. So what of any regulations or legislation? How would that be more effective? I'm just trying to get to the root cause of this ineffectiveness, this an inefficiency response. We need regulations, and I'll have to say this in English, if you don't mind.
I'm sorry, but some of the legal words I don't know in French. I try. The order in councils, the order in council that would be necessary to make for mandatory exchange of data between the federal government and the provinces is not a controversial thing. It is something that Parliament put into the law in, I believe, 2004 or 2005. It simply should be used. We should not let our preconceptions about the appropriateness of what the province may do or what the federal government may do stand in the way of a clear reading of the law. And you as parliamentarians created that law on sharing, and I'm grateful to you for doing so because it's a very useful tool, but it does need to be used. And I think Dr. Fisman would probably be able to add something to this.
I'm not sure. I could add my perspective as a researcher based in Toronto since 2006, and I've always found the failure to make accessible data that are paid for, assembled, and cleaned on the public dime, make those available to Canadians in a manner that doesn't threaten anyone's privacy or threaten anyone's well-being. I've found it astounding for a long time. A lot of my work since I've come to Toronto uses the National Hospital Discharge Survey from the United States, which is pretty similar to the stuff you get from CIHI, except that if you ask for the data online, the CDC FedExes it to you and they pay for the FedEx, whereas if you ask for the same stuff from CIHI, you pay them. So no, I don't understand. I think there's a much deeper issue than COVID, and I thank my colleague for flagging it. We have I've called it a culture of data hugging in Canada, and it does need to change. It harms us all.
Thank you, Mr. Theriault. We go now to Mr. Davies. Mr. Davies, please go ahead. 6 minutes.
Thank you. Dr. Fissman, last week you were interviewed on TVO and you said, I think there are a lot of folks who are itching to declare victory and open things up again, which is a bit of a problem because the reason that infections are subsiding is because we have distancing in place. Dr. Fissman, are you concerned that some provinces and territories may be moving too rapidly to reopen?
You know, I think my own is. And I appreciate tremendously. I appreciate the pressure that our premier's under. I think he's done a marvelous job given the cards he's been dealt. But I'm also aware that there are a lot of folks who want to get back to business. I'm not sure whether doing a screen share on Zoom is part of parliamentary committees, but we are looking at reproduction numbers here in Ontario. That's the number of new cases per old case. And what we see is that disease is clearly surging over the last week in Toronto and Peel in particular. Part of that is there's been liberalized use of testing, which drives numbers up. Part of that is probably anticipation of greater economic opening. I think we may get a couple of rude bumps along the way. I think ultimately distancing will be our parachute. And if things start to look too grim, I think they'll be able to close things back down again. But yes, I'm concerned that there's tremendous momentum to get folks back to business. I think there's a lot of economic activity that could resume safely in the province of Ontario. Ontario is a big place. It's bigger than France. And we've got regions, we've got Dr. Adoran referred to the city of Kingston has had 1 or 2 cases over the last 10 days, but they're subject to the same blanket lockdown as is Toronto and Peel, which have a couple of hundred cases a day. So I think more.
Okay, well, if I might sort of direct you to maybe some things that we should be doing. You also said in that interview, predictably, as we reopen, we'll see a resurgence of disease.
Right.
That's exactly what we see in Korea and Germany this week, 2 places that controlled their initial epidemic faster than we did and are moving towards revitalization. They've seen resurgences just as Singapore did before them and just as Wuhan has last week. So what do you recommend we do, given that you see resurgence? What steps should we be taking to get in front of that, if there are any?
The resurgences will happen. That's just how this works. It's simple math. The reproduction of a disease is number of contacts times probability of transmission per contact times how long are you infectious for. And we can forget about immunity right now because immunity is low. Even if it's 5%, it's too low to bring the reproduction number down. So as contacts go up, the reproduction number predictably goes up.
Doctor, could you please hold the mic, please?
Apologies. We're going to go too far. We're going to try to open things up. We will go too far, but that's why we need strong surveillance systems to see that as it happens.
So I want to move to testing, and maybe you and Dr. Ataran can comment on this. We hear repeatedly at this committee from every expert, we have to test, that it's key to getting control of this disease and reopening. Yet, we know that we've barely done 1 million tests since January. Wuhan is gearing up to do 1 million tests per day.
Right.
We are behind Germany. We're behind South Korea. In fact, Dr. Tam's own target of 60,000 tests a day, we're barely half of that. Why are we unable to test at the rate that all experts are telling us we need to? Where is the problem here?
I don't know, and I think you have Mr. Ciceretto here is an expert on how labs work and could probably give you a more meaningful answer than I could. My concern at the moment, because we do work with local public health units, is it's not just the testing. If people are saying we're going to do contact tracing once we open up, and we're going to track the contacts of cases, as they did in Korea, they had, I think, a couple of hundred secondary cases associated with a nightclub outbreak. I don't think that we could do that. We have legs all the way along, and it gets back to the 1990s technology where it takes time to test. The tests get faxed. It takes a while for them to percolate through the public health system. And by the time you're actually doing contact,
I'm sorry to interrupt. I just want to give Dr. Ataran a chance to weigh in on this too. Other countries are testing at much higher rates. Why can't Canada do it?
I again am not a testing expert. What I can say is that it's obviously a systemic and administrative problem, because for Ethiopia or Rwanda to be surpassing us in testing, they're getting the reagents and supplies from somewhere. They are pulling it off. And I did mention the city of Addis Ababa, the capital of Ethiopia. They have actually sent health workers around to every door in the city already to interview people about their travel or exposure history and test them if necessary. If Ethiopia can do that, I refuse to believe Canada can't. And we just need to understand better. And I am not the person to give you the answer what the administrative hold up is in the testing. But it's clearly administrative, not scientific.
Thank you, Dr. Ataran. One quick question to you. Your chart spoke for itself. The question I have is, why is Canada performing below comparative countries like Australia and the other countries you mentioned? Your chart clearly shows we are. What are the reasons for that?
In terms of bending the curve or the testing specifically?
Bending the curve, I'm sorry.
In terms of bending the curve, look, Dr. Fisman can be more detailed on this, but it's clear that we have not adopted as rigorous a lockdown as some other countries have. We've also had a slow burning problem in the care homes. And this has taken what could have been a sharp peak and broadened it into something of a plateau. I am very uncomfortable with the fact that we are opening up without the testing at the necessary level or the tracing. I'm not saying I don't want to open up. I hate being locked up as much as anyone else. You should see my children. But there has to be groundwork done. And it is the fact that the governments of this country, some of them, especially the federal government, just haven't done the groundwork.
Thank you, Mr. Davies.
Thank you.
So that ends round one. We will start round two. Mr. General, please go ahead. 5 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for joining us here again today. I wanted to address Dr. Khan and some of the comments you made, but in particular, was hoping to get a bit of a grasp on when Blue Dot, obviously ahead of the curve, if you will, early on, when they provided the first data regarding the coronavirus to the Public Health Agency of Canada.
Yeah, thank you for that question. So as I mentioned in my opening remarks, we had our surveillance system had picked this up on December 31st. You may also be aware that the Public Health Agency of Canada has a platform called GFIN, or the Global Public Health Intelligence Network. There are some parallels with the platform we're using. I think perhaps we may be using a bit more of machine learning and artificial intelligence in our system. So I believe with respect to just awareness of the event in Wuhan, this was at a similar time. I believe it was somewhere around the end of December, beginning of January. We have had, as I mentioned, a relationship with the Public Health Agency. We're going past detection of threats and then looking at dispersion, how they might spread, where they might go to next. All of the systems that we use internally, software systems, all of the internal data on commercial flights, passenger movements around the planet, all of those are accessible and available to the Public Health Agency. This is part of our partnership. I also did share the results of some of our analyses directly with Dr. Tam back in early January. I believe it may have been January 4th or 5th. A few days after New Year's, and so had communicated some of our initial findings, and then had a follow-up meeting. I think it was around the 9th or 10th of January to discuss some of this in person.
So what information exactly then did you provide? Did you provide that information from December 31st that you had attributed to the beginning of this, or what information was it exactly?
So because the Public Health Agency already has a surveillance system, and GFIN had picked up news of the outbreak in Wuhan around the same time as Blue Dot, we didn't send them that information because that was something they had already had access to. What we have been working with the Public Health Agency around contextualizing risk, understanding that something is appearing in the world is very different than understanding, well, what risk does it present to Canada, and where are those risks greatest at this particular moment? Is it British Columbia? Is it, Halifax or somewhere else? And so we shared some of our findings on the movements of travelers across the world with Dr. Tam and her office. And then met in person to discuss some of the results, and more broadly, really the need for systems. We had some earlier comments about data internally within Canada. We're clearly not a closed population. We are a microcosm of the world, one of the most connected populations on Earth. So really critical for us to be having better systems, not only to detect threats, but quickly assess what risks they present, so that we can be a step ahead and mobilize our resources, heighten our surveillance in the right places at the right time. But to kind of share with you, the specifics were really around the risks associated with the events in Wuhan, and that was really just a few days after New Year's, early January.
Did you make any recommendations at that time in terms of shutting down borders and what that would mean to Dr. Tam and perhaps her team at that time?
Well, we discussed obviously what the risks are, but of course, as you remember, early January, we didn't even know this was a coronavirus. Clearly, it caused enough concern from our end, just because there were some parallels to the SARS event in Guangdong emerging, in late 2002. So we had some concerns given the wet
Dr.
market.
Khan, could you raise your mic, please?
I'm sorry about that. Some concerns just given the parallels to SARS. However, as more information became available, as soon as we knew this was a novel coronavirus, we did follow up directly with Dr. Tam and her office. Obviously, they were aware, but our concerns at that point were, we know that novel coronaviruses, the last two, MERS and SARS killed a third and 10% of their patients, respectively. They have no vaccines, no known effective antivirals. A novel coronavirus means the whole world is susceptible, and that's a lot of fuel for an outbreak. And it's in the middle of winter time, which is when you've got respiratory illnesses. So signal to noise and detecting this behind a whole background of febrile illnesses, that certainly caused us quite a bit of concern. The last point I guess I will make is I believe it was January 13th when the first case was reported in Bangkok. By the way, coincidentally, was the top city we had identified as being at risk. At that moment, we knew that this was not a few dozen cases. In order for there to be in a city of 11 million cases showing up in another city, we had to be dealing with hundreds, maybe even thousands of cases. And so that was really the moment where we became quite concerned. But of course, with emerging diseases, unfortunately, you learn as you go. You don't have all the answers, and you have to make decisions as new information becomes available.
Thank you, Mr. General.
Mr. Chair, do you mind if I just request Dr. Khan to share that early information that he provided to Public Health Agency to the committee?
Sure.
Thanks.
I'd be happy to do that.
Thank you, Mr. General. We go now to Dr. Jaczek. Dr. Jaczek, please go ahead, 5 minutes.
Thank you very much, Chair, and thank you to all the witnesses. This session has certainly been fascinating, a real divergence of views, especially from the first three witnesses, and thank you all three for your very considered opinion. We go from one extreme with Dr. Ataran saying that we haven't gone nearly far enough to Dr. Shabas saying that perhaps we have gone too far. So I think as a member of this committee, of course, we're very interested in all your opinions, but part of what we need to do is find some commonality where there is agreement. And the area where there seems to be agreement and where we have heard a great deal from many witnesses, that there needs to be more of a national data surveillance system as it relates to public health. And it's been exemplified by many of you that, in fact, provinces are collecting data differently. Even in the use of the case definition, there has been a difference from province to province. And so I would like to ask Dr. Shabas, with all his experience and having known him for so very many years in the trenches, both in urban and rural settings. You also, at the end of your remarks, made a comment in relation to a national surveillance system. And so I'd like to hear from you, what kind of data would you like to see? Where are the important areas that need to be collected? I'm sure you had to make decisions based on inadequate data or not as much data as you would have liked to have had on many occasions. So could you flesh out for us how you see that national surveillance system?
Yeah, thank you, Helena, and thank you again for arranging my my invitation to this meeting. It's been great. It's been fascinating listening to David and Amir, and maybe at some point I'll have a chance to rebut some of the other things that have been said. But the notion of having a national agency is something that we were always very envious of the Americans, and they had the Centers for Disease Control, which was a highly respected agency that led and took the high ground, was where everyone turned to for advice and direction and guidelines. And we had the old Laboratory Center for Disease Control in Health Canada, and there were some very good people there, but it didn't have the same clout. And
Dr. Shabas, could you speak a little bit closer to the mic and maybe a little bit slower for the interpreters?
That's fine. So the idea emerged almost 20 years ago. I actually wrote an editorial in the Canadian Medical Association Journal on this, really proposing a national agency that would fulfill some of those roles. And I think we had an opportunity 15 years ago after SARS, when there was this surge in interest in public health and improving our national public health capacity, which led to the
Pardon me, Dr. Shabas, we have interpretation is stopped. We'll suspend for just a minute until that resumes. So Erica, if you wouldn't mind let us know.
So Dr. Chavez, if you could try and get as close to the microphone as possible and really
hoped we would adopt would be not so much of a federal agency, but of a national agency, because we had some resources with the federal government, but it was also a time when Ontario was developing Public Health Ontario, when British Columbia was augmenting the BC CDC, and there was I felt a real advantage in developing a sense of cooperation between the federal government and the provinces, because the reality is that it's the provinces that collect the data, and it's the provinces who make most of the public health decisions. And you don't have the federal authority to tell them what to do. They're going to do what they want to do, and the only way to get consistency in a truly national approach to a problem like this is to get people to buy in, to get people to be willing to do it because they think it's the right thing to do, and because the prestige of the direction that they're getting from the national agency is sufficient for them to I'm not going to say fall into line, but for them to be consistent with their approach. Now, we don't ever expect everything to be the same. Why should British Columbia, here's a great example with COVID, why should British Columbia be doing what Quebec is doing? Very different sorts of situations. But it's certainly, I think we'd all be much happier if we knew that there was a common purpose, if there were common objectives, if there was a common directive. So I'm maybe hoping, maybe a little naively, that there'll be another surge in interest in public health. I'm sure there will be after COVID, after the COVID crisis comes and goes. And I hope we rethink how we set things up. That's not a criticism of the Public Health Agency of Canada. I just think it would function better if it was better integrated with the provincial agencies, and if the partners, if the provinces and the federal government were truly partners in this.
Dr. Jaczek, your time is pretty much up, but because of the problem in the middle there, I'll give you one more question.
Thank you, sir. Thank you, Chair. So, Dr. Khan, perhaps I can ask you, obviously you and Blue Dot have been very helpful to the Public Health Agency of Canada. What kind of interactions have you had and Blue Dot had with the provincial agencies, such as Public Health Ontario?
Mm-hmm. Well, we have had interactions with the Ministry of Health in Ontario and have been actively working with the province there. At Blue Dot, we're a team of about 50 people or so. We're also working via Global Affairs Canada and actually
I'm sorry, Dr. Khan, microphone.
Okay, so sorry about that. We are also working with Global Affairs Canada to support capacity building, as I mentioned in my opening remarks, in 10 countries in Southeast Asia. We're working in the state of California. So, while in many regards, I think, we would be very eager to be supporting public health responses across the country and working closely with the provinces and territories. I think we've had in some ways an issue with respect to capacity to do this in the midst of the COVID-19 pandemic. But we have had engagement at the federal level and are producing analytics across the entire country on a week-over-week basis. And also with the province of Ontario. So I'm not sure if that answers your question, but a lot of the kinds of analytics are focused on understanding issues related to social distancing, how that is related to epidemic activity, but also keep in mind, while today we're in a bit of a lockdown, as the economy reopens and we have a highly susceptible population, we're going to have to start, we may find ourselves in the same place as New Zealand in the future, where we have to start looking outward again and starting to think about introductions that could trigger the next wave. So we've been involved in supporting both an internal look and tackling this here in our own backyards, as well as monitoring the global situation and potential introductions.
Thank you, Dr. Jaczek. Dr. Kitchen, over to you. 5 minutes, please.
Thank you, Mr. Chair, and thank you, everybody, for your presentations today. It's been greatly appreciated. Dr. Attaran, yesterday I spoke to Dr. Tam and asked her a question, and it was about building data sharing between the provinces and organizations, et cetera, with the federal government. And you've actually answered a lot of that question that I had for you. But furthermore to my question to her, I was asking her about demographic data, in particular how New York City has come up with a lot more demographic information, et cetera. And she had indicated to me that it's on their public health agency website. So I took the opportunity this morning to go onto that, and with some help from my staff, I managed to finally find some information on that. And they talk about a lot of the updating of data as of today, and they talk about 4,201 cases of clinical presentations that were presented, and of those 561 cases, or 13%, clinically or radiologically were diagnosed with pneumonia. But my point about that is provided a lot of information. So then all of a sudden I find a little bit farther down a little statement, and I'll read it to you. And it basically says, the epidemiology update is based upon information received from 38,746 cases. Not all data fields are complete. Also, cases with data available are included. So bottom line is they put in, they're providing inappropriate information on the data that we have. How is it that we ask you or other epidemiologists to come up with data and provide modeling when we put this out with inappropriate information?
Dr. Kitchen, thank you for a very intelligent question. You're exactly right. You mentioned that there were roughly 38,000 cases in the data that you looked at. I'm going by memory here, but I think we've had about 80,000 cases reported in Canada so far, so that's under 50%. What that means is that at the high water mark, anyone like Dr. Fisman, Dr. Khan doing modeling, or me when I do it in my amateurish way, we are working with less than half a deck.
Right, and
that's, there's obvious problems with that.
And when the public health agency is making these decisions based on World Health Organization data, which is coming in from China or wherever, which is inappropriate, how do you come up with that proper information? Dr. Fisman, do you have any comments?
Tell you, my group at U of T call ourselves the data raccoons because we've sort of managed to thrive for about 15 years on data that most people regard as garbage. So it's sort of a bit of a normal state of affairs for us in terms of public health data analysis. The stuff we have is pretty good. I mean, here by our standards, working with folks here in Ontario, there's been a modeling table convened over the last few weeks, and we've been given access to case files. And there's a lot you can learn, but there are also a lot of fields that are missing. We could do potentially better, but I think it's also important to remember that those fields are being filled in by very harried frontline public health epidemiologists and a lot of missing data. I suspect what you're seeing from Public Health Agency of Canada is they're putting out the data where they have complete fields, and that's their way of dealing with missings. Missing data is just part of epidemiologic data analysis. It happens no matter how good the data are that you've got. So I'd sort of want to know more about how they've made those decisions, but sometimes it's good enough.
Yeah. And that's a challenge, though, when you don't have proper data and you don't understand that. I'm going to go on a little bit further. And Mr. Ciceretta, you talked about high-quality antibody testing, and we've heard a lot of people from you today about testing from all the witnesses. Last week, Health Canada approved the first serological test for use of detected antibodies in those who contracted or may have contracted COVID-19. The approved serological test comes from an Italian biotechnology company. Do we have the capacity to produce these tests domestically? Do you know that?
So thank you for the question, Mr. Chair. The answer to the question is we do have capacity. The particular test that was approved was a company called Diasorin. We don't particularly have that platform that testing platform, and so that's critical. Could we acquire it? Yes, we could acquire it. There are other companies that we're working with right now, large diagnostics organizations that are looking to get Health Canada approval as well for a serological test. But once that happens, I have 200 collection centers and 850 phlebotomists that can collect those samples and bring them into a laboratory onto existing test platforms that we have today that could do that testing quickly, efficiently, and accurately.
Thank you, Dr. Kitchen. Go now to Mr. Kellaway. Go ahead, 5 minutes, please.
Thanks, Mr. Chair, and hello to colleagues, and really a special thank you to the witnesses today. To echo Dr. Jessek's comments. It's interesting to see such a rich series of viewpoints, insights, opinions, and also backgrounds in a variety of areas. So I really appreciate it. It's very illuminating. Dr. Khan, I find your work very fascinating, and in terms of the technology you use, and I want to not necessarily look to the past, but look to potentially a second or third wave. And can you talk about how your technology may be able to be used to track and identify in many ways the second and third wave? And could you say, or could you illuminate a little bit on what the biggest risk factor that could trigger the next wave?
Mm-hmm. Yeah, thank you for that question. Maybe the way I could sort of frame what we have been building is, I'm going to use a bit of a metaphor here. The smoke detector.
Microphone, please.
I'm sorry. Okay, I'm still learning. The smoke detector and the fire extinguisher. We've been building for 6.5 years systems to be able to detect threats early. Because we know, as I mentioned, time is our most valuable resource. And to be able to quickly go from detection to what kind of risks are we facing, not just dispersion of the disease, but what kind of disruption might occur. And that is very important because diseases spread around the world all the time. They don't all cause outbreaks or pandemics. That is a complex requirement because every disease behaves differently. Zika virus is different than Ebola, which is different than COVID-19 or measles for that matter. We've been spending a number of years building up that capacity to have a bird's eye view of what's happening around the planet and to be able to relate it to geographies across the planet and do this in really a matter of seconds. With respect to once an outbreak starts to spread and is now occurring locally, this is where we have been using, again, I want to underscore anonymously, just the pings, the digital locations from hundreds of millions of mobile apps and mobile devices. That kind of information can help us understand, ultimately, this is a virus that spreads, as Dr. Fissman mentioned, through the movements and interactions of people. These are really rich data sets, over 3 billion data points a day, that can really allow us to understand how those movements are occurring so we can then start to anticipate, how the epidemic might evolve. It also allows us to generate insights about some of the non-pharmaceutical interventions like physical distancing or recommendations for, quarantine. Are those being adhered to at a population level? I do want to highlight, we're not tracking anyone who's infected or their contacts. We're looking at population movements. With respect to going forward to the next wave, I think the simple reality is no one really quite knows what this is going to look like and exactly how it's going to unfold. We are dealing with, a completely novel disease. We have certainly concerns that as we get into the latter months in the fall, we tend to know that coronaviruses tend to be in cooler, drier climates, maybe more efficiently transmitted. But as that occurs, currently, we are relating a lot of this mobility data to understanding how the epidemic curve is evolving. And perhaps there are lessons that we can learn about which geographies and which locations seem to be opening up society in such a way that they can, generate some sense of normalcy and some kind of economic activity without having an exponential increase in the epidemic. And I think that's the $64,000 question now. How do we do this gracefully? How do we thread the needle? These are things that I don't know that anyone candidly has the answer for just yet, but I think it's going back to the point about surveillance and testing and monitoring is critically important because this is, as we start to reopen society, this is going to be incredibly important for us to be watching very closely what the response is in terms of epidemic activity and transmission. So I hope I've perhaps given you a little bit of a sense of what we're thinking going forward.
You have, just in terms of one of the items you mentioned around, I think you mentioned measuring disruption in society, or maybe I miscategorizing that. Can you unpack that a bit?
Yeah, thank you. It's a really big and a very important issue. So the kind of 4 Ds that we work on are detection, dispersion, disruption, and dissemination. And detection speaks for itself, early detection. Dispersion, how these things leap across continents in hours. how do we anticipate the next move? Dispersion, without getting into a lot of detailed epidemiology, what sometimes is called the infectious disease triangle is disruption or an outbreak is really lies at the crossroads of the characteristics of the microbe, the germ itself, the characteristics of the population, and the environmental conditions. So Zika virus is not going to spread here locally in Toronto because there's no mosquito, it's too cold, but it might spread in Miami in July, but maybe it might not in January. That is a very complex set of data, and we're bringing in hundreds of data sources from real-time satellite data to insect observations to demographics, et cetera, so that we can do this for over 100 different diseases. So we can try and get a sense, are the necessary ingredients there for this to actually cause a disruption, to cause an outbreak? You can imagine this is not a data problem. It requires deep subject matter expertise integrated with deep data analytical expertise and data science. So this is the area that we're actively involved in. I mean, we're well on our path and well on our way, but this is a formidable challenge that really is, it's going to take years.
Thank you, Mr. Kellaway.
Thank you very much.
We go now to Mr. Thériault. Mr. Thériault, please go ahead.
Mr. Thériault, please go ahead. 2.5 minutes. Thank you very much, Mr. Chairman. My question is directed to Mr. or Dr. David Fisman. And perhaps Dr. Chabas would like to chime in as well. We still don't have a vaccine. We don't have any antiretroviral drugs. We're just getting started with the serological testing. And there is a willingness to end the lockdown. But that said, we seem perhaps to be a bit hasty when it comes to this notion of herd immunity, with no certainty as how to the data on COVID-19 ties in with any potential herd immunity. So could you just tell us where we're at in terms of community or herd immunity when it comes to COVID-19? Just give us a bit of the lay of the land in that respect. And in the event that we were to proceed with the kind of ideal end to the lockdown, at what point will we, in fact, have an appropriate and necessary level of herd immunity for things to be safe?
Sure. Thank you very much. There are a lot of moving parts here. Herd immunity can be approximated as a function of the reproduction number of the disease. The higher the reproduction number, the more people need to be immune for the disease not to take off. That's why we see measles outbreaks when vaccine levels fall off just a little bit, because measles, the reproduction number in a susceptible population is about 20. So you can get 20 new cases from an old case. This is a much less infectious disease. The reproduction number is somewhere between 2 and 3. That means that you need somewhere between half and 2/3 of the population immune to have herd immunity, so that if you bring in an infectious case into the population, you don't have an epidemic. Where are we right now? We don't know. I've been doing a running meta-analysis on seroprevalence studies as they've come out. I'm up to about 50 of them, and you can compare antibody prevalence in populations to what those communities think they have going on in terms of the number of cases that they have. And it's called a cumulative meta-analysis, just adding study to study to study. And the long and short of it is I think we probably detect about 7% of cases. So we have an inflation factor of somewhere between 10 and 20-fold. If we look at Canada with 80,000 recognized cases, that would be somewhere between 800,000 and 1.6 million cases in reality. That puts us, I am going to get hung up trying to do the math on the fly, but I think that would be 1.6 million would be 4%. So, if we're there now, New York is well ahead of us. New York has good seroprevalence data. They're at about 15%, but they had to go through hell to get there. They did experience wholesale collapse of hospital systems in much of the city, including the Bronx, including Queens, to get to 15%. That means that they might be able to get to herd immunity, 50, 60, 70%, by going through that a few more times. And I don't think they will allow that to happen. They've lost approximately 20,000 New Yorkers to get to that point, of all ages, I would add. So what we have to do right now is, a lot of countries around the world, indeed a lot of provinces in Canada, show us that we can knock this disease down to low levels, and then we can use good public health practice. I agree with Dr. Shabas, you can't do contact tracing if you're having 200 cases a day as we are in Toronto. It's just too much. But if you're having 5 cases a day, you sure can. And if you're testing a lot, you sure can. And so what you need to do is use the distancing to knock the reproduction number down. We're still around 1 in Quebec and Ontario. And I would add that the Canadian epidemic at this point is a Quebec and Ontario epidemic. The other provinces have got the job done at this point. But if you can do that, then we can start to use other public health measures like contact tracing to keep a lid on this, get through the summer and allow the economy to reopen. We haven't touched on masks at all. There's pretty good evidence at this point. There's ecologic evidence that the countries that are doing much better than us are mostly mask adopting countries. So you can argue the science and we can have a symposium in 5 years about who was right, or we can use the precautionary principle and move towards masks now, which I think Dr. Tam has started to do. So there's a lot that we can do to keep that reproduction number low and reopen our economy to a degree, and muddle through, basically, because there's exciting stuff happening with vaccines. There are RNA vaccines which weren't on the table 10 years ago. There's a really exciting live virus vaccine from the UK where AstraZeneca, the pharmaceutical company, is manufacturing the vaccine at scale while the trials go on. So if the trials are a success, they're going to have millions of doses ready to put into people's arms. So what we need to do is avoid mass death situations until we can get through to a point where we can effectively deal with this pandemic, which we will. But it's a matter of tenacity, and it's a matter of patience, and it's a matter of competence. And that's very patchy across the country. Some places have shown it, other places haven't. And I'm sad to tell you that I feel that my province at a provincial level is one of the places that hasn't shown that, although individual local public health units have really shone and distinguished themselves.
Thank you, Mr. Theriault. We go now to Mr. Davies. Mr. Davies, 2.5 minutes, please.
Thank you, Dr. Fissman. Last week, you stated, I continue to be concerned that there hasn't been enough attention given to epidemiology in kids. I know folks are starting to study that in Germany and Switzerland, but we haven't really studied it in North America. And then you said, for those of us who have been really concerned about the possibility that children may be important vectors of this disease, given that we haven't done much research in North America and you're concerned that children may be important vectors, how do we square that with sending our kids back to school?
It's a dilemma. And honestly, I think I mentioned earlier, the signature of this disease is it takes off with big gatherings. So there's a lot that you can probably reopen economically safely if you stay away from large gatherings of people. The one big gathering that's really, really tough to cancel and which has huge economic implications is schools. That's the hardest thing. And the reason to be concerned about aggregating kids is that we see the evidence from other respiratory infectious diseases. Kids don't die of them, but they are tremendously good at transmitting these diseases.
So that being the case, why would we be sending kids who are vectors of this disease to gather in large gatherings to come back to homes where they may be in contact with seniors?
Yeah,
and I don't see what the dilemma is there. What's the dilemma?
I think that the idea is that economically it holds a country back. Even if we've got 40% of our workforce able to work from home, for the parents who are working from home, it's often difficult to get your job done if you're minding children in parallel. But yeah, it's an issue. Countries like Korea have kept their schools closed. Hong Kong continues to have their schools closed. I think they're just starting to reopen as they have approximately 0 cases at this point. But I think places with good public health leadership have done it very cautiously, because kids are the transmitters of infectious disease for many respiratory diseases, even if they themselves tend not to be sick by them.
Thank you, Dr. Khan. Just quickly to you, I know you did a commendable job. An article in U of T News said that Blue Dot was among the first to warn the world of potentially dangerous new illness, COVID-19. And you rang the alarm on December 31, 2019, before both the U.S. Center for Disease Control and Prevention or the World Health Organization. You also predicted the next 11 cities where the novel coronavirus would hit. You're quoted as saying, we didn't necessarily know it would be of this size, but what we did know is that it had the ingredients. When approximately were you aware that COVID-19 or the novel coronavirus had the potential for serious, significant, widespread transmission?
That was...
Microphone, please.
Yes, sorry. Thank you for the question. I think the point, this is sort of a gradient of, I would say literally December 31st, first seeing that information caused certainly some alarm. Around the middle of January, and I have to double check the exact dates when the first case showed up in Bangkok, I'll kind of give you a little bit of a sense of the increasing concern. When we learn that this is a novel coronavirus, I believe that's somewhere around January 8th or so, there's concern for all the reasons I mentioned earlier. MERS and SARS, and comparing those, no vaccine, no effective antivirals, no underlying immunity. We're in the middle of flu season. What we had been learning up until that point in time is the number of cases that were being reported in China were in the dozens. When the case showed up in Bangkok, which was the top place we had concerns about because of the movements of travelers from Wuhan out into the region, in a city of 11 million, the math doesn't work if you have a case show up in another city, and knowing the volume of travelers leaving. That was the moment for myself and our team where we really were quite concerned about, and again, we didn't have all the answers, but we were quite concerned that this is a novel coronavirus. The outbreak is much larger than it appears to be. And this inevitably is telling us this is not just a spillover event. This is not just the people who were at the market that got infected. If there are hundreds or thousands of cases, this has got to be something that is more efficiently being spread from person to person. So it was roughly around the middle of January that we had some, serious concerns about how this might unfold.
Thank you, Mr. Davies.
Thank you.
So that brings round 2 to a close. We start round 3 with Mr. Weber. Mr. Weber, please go ahead. 5 minutes, please.
All right. Thank you, Mr. Chair, and thank you to all our presenters and your opening remarks. Very, very interesting indeed. My first question to Dr. Attaran. Dr. Attaran, thank you for sharing your paper on the pandemic data sharing with the committee. In this paper, you mentioned back in 2003 the SARS issue and how the World Health Organization demanded epidemiological data from Canada about the scope of the epidemic, particularly back then in Toronto. But the problem was that Canada had no way to fulfill the World Health Organization's demand because of the jurisdictional fight that you described today with regard to data sharing. Now, because of that, Health Canada was in no position to answer the World Health Organization's questions, and so they grew afraid of Canada. And they thought that Canada was concealing this epidemiological data, which then resulted in the World Health Organization recommending against travel to Canada, making Canada one of only 2 countries, that and China, as the 2 countries that they have sanctioned back then. Sadly, I see this occurring again. Do you see that, Dr. Attaran? Do you see this occurring, and what the implications will be to be sanctioned once again?
Mr. Weber, you summarized that exactly right. Back in SARS, there were 2 countries in the world that got slammed with the WHO travel advisory, and we were one. And China, not exactly having been honest, shall we say, was the other. Now, we weren't trying to deceive the way China was. We were just unable to be honest. We were unable to get the data from Ontario to Ottawa and then onward to Geneva, where WHO is. Nothing has changed. That is a risk that could repeat itself. Yesterday, I believe, was Dr. Kitchen who asked about the multilateral information sharing agreement, which is an accord between the provinces and the federal government to share data. It is so secretive and ineffectual. To this day, we don't know which provinces have signed that agreement and which have not. Can you believe it? The Public Health Agency, I've asked them that question directly. Which provinces have signed the information sharing agreement, which haven't? They won't answer the question. And parts of that agreement actually stand in the way of data analysis, the sort that Dr. Fisman does. Under that agreement, provinces have to give their permission before analyses using their data can be published, which means they have the ability to suppress analyses that can save lives. It's terrible.
It's unbelievable. It really is, Dr. Adoran. Thank you for sharing your testimony today. Dr. Fisman, again, thank you as well. And thank you and for your work, your commitment, and your sacrifices too, along with all healthcare workers in Canada. Thank you all. Dr. Fisman, you talk about some of the best practices around the country, and I think it was Nova Scotia who you indicated they hunt the virus, and how Saskatchewan, they deal swiftly to contain in areas of outbreak. And then you talk about Alberta and how they've scaled up their testing and that they're the most potent and aggressive testing province in the country. And so I'm just at odds here. I don't understand how come Alberta can do it, but the rest of Canada cannot. Where are they getting their testing material? What's their secret in Alberta?
You know what? I'm not sure to what extent I can talk about private conversations in this public forum, but as I speak to colleagues across the country, what is clear to me is that the places that got the job done were aware of their deficiencies as laboratory systems and worked with commercial partners to automate processes in their labs. It's one thing to be testing 100 specimens a day. It's another to be testing 10,000 a day. And I think that the laboratories that are able to have high throughput here, and we do have folks, I mean, Mr. Ciceretto is probably the better one to answer this question. We do have folks in the country who know this stuff, you know, from the time the specimen arrives until the report goes out to the public health unit, not by fax, but electronically, that can be tremendously streamlined. So you don't get the bottlenecks that we've had in Ontario. I think a lot of the problems got blamed on supply chain, but clearly as supply chain has cleared up, it's still a rocky ride. I think in Ontario, there have been a lot of politics as well. I think you see that. We have had access to some testing data via the modeling process. You see that there's still this hugging going on where even as testing is supposed to get dispersed out to hospital labs and private labs, it's still getting hugged by the public health laboratory system. So I think in a time of national crisis, it's time to check your ego and work with whoever you can work with. It's actually the folks in Newfoundland. It was a remarkable experience to interact with them because, and perhaps this is a size thing, but it seemed a lot to me like an ego thing, where what you have is you have a provincial working group that has some former politicians, you have some leaders from health, you have leaders from business, and you have a couple of academics, and they're all at the table and they're all exchanging ideas. And it reminds me of the children's story Stone Soup, where everyone brings something and puts something in. You know, and at the end of that, they all have a good soup to enjoy together. That's how they do it in Newfoundland. And it was a revelation to me as someone coming from Ontario who's used to being asked for information that then goes off into a dark place, and you're never really sure who's seen it or who's used it or who's responded to it. It's just a very different way of doing business, and I think it served them well. They got the idea of hunting the virus from Iceland. They looked over to the east and saw, well, we've got Canada over to the west, and then we've got this other country over to the east, and the country to the east is doing a bang-up job. Let's talk to them. So I think being humble and looking for folks who are doing this better than you and learning from them is part of the magic.
Absolutely.
Thank you, Doctor. Thank you, Mr. Weber. We go now to Mr. Van Bynen. Mr. Van Bynen, go ahead, please. 5 minutes.
Thank you, Mr. Chair, and thank you, Dr. Fisman, for joining our committee today. It's so refreshing to hear such a wide variety of perspectives, and that certainly helps us in developing a good understanding of the situation that we're trying to find some solutions for. It's my understanding that you co-authored a study that examined the impact of enhanced contact tracing and restrictive physical distancing measures in comparison to a combination of enhanced contact tracing and less restrictive distancing measures. Could you please share with the committee the findings of your study and what the implications may have?
Of course. So I think what you're referring to is our paper that was in the CMAJ, the Canadian Medical Association Journal, in March. Our model looks a lot like most other models by competent modeling groups. It looks like the publication by a guy named Steve Kistler in Science that happened about a month after. What we projected was that reducing transmission through a variety of means can knock down the reproduction number of the disease and prevent your intensive care units from overflowing. Something we learned, which we didn't really anticipate, was that a lot of death in Ontario would come in the long-term care facilities. We knew that long-term care facilities were vulnerable, but had assumed as we were doing our modeling that people would actually try to protect them, which turned out not to be the case. So what we found is various combinations of case identification with contact tracing or just straight physical distancing are sufficient to knock the reproduction number down enough that your ICUs don't overflow, which has been the case in Canada, which is wonderful. So moving forward, we've now got a second iteration of that model in press in a journal called Annals of Internal Medicine, where we've been, thanks to the provincial modeling table, been able to calibrate the model. That means we fit the model to real data. We couldn't do that beforehand because we didn't have an epidemic yet to fit to. We can fit it to ICU occupancy in Ontario, and we can fit it to hospital death. The long-term care stuff is very challenging to try to fit into any sort of model. And what we see is that basically the lower we go in terms of disease activity and the slower we reopen, the longer it'll be before we have a resurgence. In our paper in March in Canadian Medical Association Journal, my colleague Dr. Chute, Ashley Chute, who I've referenced previously, is a brilliant modeler, came up with the idea of dynamic social distancing, which again depends on really good public health surveillance. So you know when your hospital's starting to fill up again, and you know you have to strengthen your distancing measures. As I say, we think the group at Harvard who were friends with may have copied that from us, and that came out in the Science paper as well a couple of weeks later. This idea, and a journalist referred to it as surfing the wave, that we're likely to go up and down and up and down and up and down with this disease for a while, until we have a vaccine, which, as I say, it may come sooner than I ever would have imagined.
Thank you. Now, yesterday I asked Dr. Tam about the provinces and the territories and their plans to be reopening their economies, as well as people starting to leave their homes as the weather gets nicer. So as a follow-up, I'm wondering, with the information obtained from your study in mind, what are your thoughts on how this can be implemented safely?
Well, as I say, and this is not our work, there's a marvelous mathematician at Waterloo by the name of Chris Bouch, who's got a paper looking at regional reopening in Ontario as opposed to just blanket policies, with the outcome of interest being how can you minimize the amount of time in lockdown? And as I say, I think we're getting some organic reopening happening anyway as the weather gets better, and that's all right. This doesn't seem to be an infectious disease that spreads particularly well in parks, that spreads particularly well as people are out enjoying themselves, as long as they're maintaining a bit of distance. This really does continue to show that it's a disease that likes big crowds in indoor places. I think our most recent super spreader event here in Ontario is in a greenhouse workers in Chatham, which fits the description to a T, 50 people infected working in a greenhouse. So when folks are in small groups, have kind of low upper bounds on the number of people they're working with, call that work bubbles. When folks are enjoying themselves outside, staying fit, getting out into parks, enjoying outside with their kids, I think that's generating minimal risk for us. But what we do need is we need good, strong surveillance systems, and this circles back to our initial conversation about testing, that let us know when we're getting into danger again, as we were in March. I do think we're going to struggle in the fall, and we need, there's a lot of kind of hindsight at this point about, this thing emerged in January, but we didn't really get serious about it until March. I think we're going through that again. Anyone who looks at disease dynamics for a living can tell you we're in a lull now, probably going to be coming back in September, October. We've got some golden time now to get prepared for a likely resurgence in the fall. So I think we do need to build those surveillance systems and get much better at this by the time we get to the fall, because we're going to have to be more nimble then. But I think there's much we can do. There's much we can do safely if we avoid large gatherings. The bubble idea is simply that, and a lot of corporations have at this point already instituted this. If you divide people up into relatively small teams, and you don't work simultaneously in the office, and you have a deep clean between teams being in the office, you've got an upper bound on how many people are going to get infected if someone comes into that bubble with infection. So I think there's a lot of ingenuity and there's a lot of wiggle room to reopen the economy safely, as long as we've got the surveillance systems that allow us to see when we're getting back into trouble.
Great. Thank you, Mr. Van Bynen. We go now to Ms. Jansen. Ms. Jansen, please go ahead. 5 minutes.
Yes, thank you. Dr. Khan, as an infectious disease specialist, I'm curious about your thoughts on the current deal that Health Canada has made with China on developing a COVID-19 vaccine. The announcement mentioned that the National Research Council is working with CanSino Biologics to advance a vaccine which is being developed jointly with the People's Liberation Army. Now, apparently Health Canada has even approved the first human clinical trial that will be run at Dalhousie University, in spite of the fact that CanSino has not published any data from its first trial phase for any sort of public scrutiny. This really shocked me. I don't know, vaccine development cycles are normally 10 to 15 years, and the shortest ever was 4 years. Our Five Eyes Intelligence Alliance has raised concerns regarding China's transparency regarding this particular pandemic, and they even denied initially human-to-human contact, and some whistleblowers have disappeared. Now, if we want Canadians to buy into a COVID-19 vaccine, wouldn't it make more sense to be working with a more trustworthy partner on this sort of thing? Does it strike you as dangerous?
Well, look, thank you for the question. I'm gonna try and see if I can tackle it. I mean, with respect to vaccine development and partnerships, I would say I'm not up to speed on exactly what this.
Dr. Khan, microphone.
Sorry, I'm not fully aware of all the details of how Canada is looking at vaccine development, perhaps with the government of China or with scientific groups in China. I think all of the points that you've raised are very important. Clearly, there is a race to get to a vaccine as quickly as possible, not only from a preventative standpoint, but also to develop therapeutics. I think I'm probably not well equipped to speak to the kind of broader ethical issues here. I'm just less informed about the specifics of this particular circumstance. But clearly, the points that you're raising around transparency are critical in developing any scientific endeavor. So I think that is a critical issue. I'm not sure if others, perhaps Vito or others, maybe want to chime in on that, but Yeah.
Well, I did have another question, not specifically for you, but my time is limited. So
okay.
If I could go back to Dr. Adoran or Professor Adoran, you mentioned that we could ask you a question about yesterday's meeting. And I asked Dr. Tam about her flip-flop on the use of masks. And up until early April, Dr. Tam stated that an asymptomatic person shouldn't wear a mask. Didn't work, it might even be harmful. And then on April 6th, she changed her mind and said a mask was good for additional protection. And her response to my question on why her message changed was that apparently new evidence had come to light. As this was a respiratory pathogen, I imagine that out of the abundance of caution, masks would have been helpful right from the beginning. Now, in your opinion, what sort of new evidence has come to light over the course of this pandemic that would substantively change the way we consider the effectiveness of masks as prophylactics?
There's no easy way for me to say this, but Dr. Tam was not being truthful. And in the week or 10 days, pardon me, I don't know the exact time span between her statement that masks were not to be recommended to the public and then changing her view that to give permissive guidance that masks of a non-medical sort could be used. In that short period of, as I say, about a week or 10 days, there was no new evidence that emerged to justify that change.
Oh, okay.
There has been additional study of masks, of course, some of it biophysics, what size particles will penetrate a mask in what conditions. But there was definitely not in that crucial window a game-changing study.
I have a really quick question, and my time's almost out. You provided a chart in your submission that showed Australia and I believe South Korea had much better pandemic trajectories than Canada. And as with all catastrophic emergency, there's never just one thing that goes wrong that causes the tragedy. And I assume that's the same thing when things go right. So what, in your estimation, are the critical things that ensured better outcomes in those countries compared to Canada?
Australia, for instance, was very quick about cutting off travel with China. It did so at the same time as President Trump did, but for sounder reasons than Mr. Trump. It was also incredibly quick at organizing coordination between the states, the provinces, if you will, and the federal government. As I mentioned, they signed an accord on cooperation on March 13th, an accord that doesn't exist in this country yet. The Australians have, generally speaking, a very strong sense of biosecurity because they are an island continent, and they have honed that over years. And so they're much more attuned to risks coming in from abroad than we have been. The error of not being tougher on travel sooner is one that we will, of course, regret for many years to come. The Australians also, I feel, were extraordinarily good at their social distancing. Now, precise measures of how aggressive social distancing is are hard to come by. Dr. Fisman would be able to speak to that far better than I could. But even from my inexpert point of view on this, it's clear the Australians did take the social distancing more seriously early on than Canadians. And that's had an effect.
Thank you, Ms. Jansen. We'll go now to Ms. Sidhu. Ms. Sidhu, please go ahead. 5 minutes.
Thank you, Chair. Thank you, everyone, for coming today. As you know, I really like all the witnesses, even though yesterday Dr. Tam and her team was here. And this committee has really been focusing on supporting Canadians, how we can help better to all Canadians. And today, I really want to say thank you, all the witnesses. My first question is to Dr. Khan. Even though you said that, your rigorous factor, you could trigger the next wave. Can you explain to the committee how your technology can be used to track second or third waves of COVID-19? What you see the biggest risk is coming?
Well, thank you for the question. I think what I would really say is the technology that we've developed, I'm kind of going back to that metaphor of smoke detector and fire extinguisher. We've really been focusing much more on developing the early warning systems that can give us a signal that there is a threat coming. COVID-19 is here now, and we're all very well aware of it, and we're now sort of more in firefighting mode, kind of, you know, grabbing the fire extinguisher, if you will, to put things out. So I would say, from the standpoint of our technology, the area where we are supporting public health decisions is around an understanding of population movements and how that is relating to the transmission of COVID-19 across the country. With respect to the next set of waves, I think I have two thoughts. One is, clearly the vast majority of the population in Canada remains susceptible, as we've heard. We either could see an uptick in cases later in the fall because of a variety of factors, including climate conditions and dynamics of how people are interacting, or we could find ourselves in a similar position to some of the countries like Australia and New Zealand, where imported cases become the catalyst for another wave. So we're going to have to be thinking both internally and externally. These are a couple of examples of how our technology is looking internally within the country, domestically, as well as globally.
Thank you. My next question is, Mr. Cicerato, I know your company is based in Brampton, and your company recently moved to provide results for COVID-19 test results online instead of over the phone. How was that increased to efficiency of your testing process? I know in Canada today, 1.3 million people were tested. And what you think, like how on online instead of over the phone, how was this increase the efficiency of your testing process?
It's thank you for the question, Mr. Chair. The ability to transmit results directly from an analyzer onto your laboratory information system and into provincial health repositories is critical. It's critical from at least two perspectives. One, from a timeliness perspective. As soon as that test result is available, you want to make sure that you're able to release it. The second, and perhaps even more importantly, is from an accuracy perspective. The minute that there's any type of human interaction of taking a manual result from a machine and then transmitting it onto a computer, there's always that risk of error. And that's not something you want, obviously.
And next question is to Dr. Fisman. Dr. Fisman, you talked about the mask adopt strategy. I know Public Health Agency's opinion on non-medical masks too. Can you explain the mask adopt strategy, how effective it is?
Pardon me, Ms. Sadu, your sound has gone really bad. Can you plug in make sure your headset is plugged in properly?
So, can I ask the question again, Mr. Chair?
We'll suspend for a minute and have this sorted out. So could you speak for a bit and make sure the mic is close to your mouth? Maybe unplug the headset and plug it back in and see if it works.
As you know, Public Health Agency's opinion on non-medical masks. You also mentioned the mask adopt strategy. How can it's beneficial to the Canadian?
Well, we don't know, but we can be highly suspicious that it would help us a lot, especially if we can get the reproduction number of the disease down to around 1. That's a tipping point. So at that tipping point, very small changes in infection transmissibility can really make the epidemic fall through the floor and go away. What you have to remember about masks and a disease like this is masks work in both directions, right? They reduce the likelihood that you get infectious particles into your nose and mouth and eyes, potentially, if they keep your hands off your face. But they also prevent you from infecting other people. With this disease, that's probably the more important part, the reduction in transmission. And the reduction in transmission happens very efficiently, even with cloth masks. The reason that's so important with this particular disease is that what we know from work of Gabriel Leung and his colleagues in Hong Kong, which was published in Nature about a month ago, is that about 44% is their estimate in Hong Kong of transmissions occur in pre-symptomatic individuals. Those are people who are going to feel sick tomorrow, but they feel just fine today, so they haven't changed their behavior. So masks can be extremely impactful because if I'm wearing a mask and I become infectious, but I don't know it yet, I don't infect you. And that's why I think there's, everybody wants to wear a mask to protect themselves from other people. And I'm fine to have folks, leverage that to get the masks on. But really the benefit, it's pretty clear. I mean, there's a reason why surgeons wear masks in the operating room, because they block extrusion of respiratory droplets that infect the patients they're operating on with bacteria. So this would be the same idea, except out in public, you're wearing a mask not to protect you necessarily, although it might, but to protect other people from you if you're infectious but don't have symptoms. And as I say, we've had reproduction numbers in Ontario and Quebec, which is basically where our epidemic lives now, grumbling along around a reproduction number of 1. In Ontario, it's been since early April. And we just can't seem to get it down. So anything that knocks that reproduction number down, if it knocks it to 0.7 or 0.6, we're going to get back to a lot more rapid economic opening up, and we're going to be able to open up more. The lower we keep that reproduction number, the more we'll be able to open up in terms of the economy while still staying safe. So to me, it's a no-brainer. And we can argue about Class 1A evidence or what have you. We can have a symposium about this in 5 years and decide what exactly the science shows. But now's the time for action. As Professor Adoran said, we're burning through $12 billion a week. Getting masks on Canadians and teaching them how to use them is basically change from between the couch cushions relative to what we're burning through by keeping our society closed. So to me, it's worth the gamble.
Thank you, Ms. Sadu. We go now to Monsieur Desolé. 2 minutes and a half, please.
Yes, hello there. Thank you, Mr. Chairman. And thanks to all the witnesses for being in attendance today and for the content that you've shared with us. It's very interesting. Unfortunately, the interpreter cannot hear well.
Pardon me, Mr. Desolé.
Comment devrait se faire?
Monsieur Desolé, s'il vous plaît. Are you on the French channel when you're speaking? Your sound is as bad as well. Could you try and unplug your headset and plug it back in?
Okay.
And then go to the button next to the microphone icon on the lower left-hand corner and make sure that your proper microphone and headset is selected. And then we'll try it again. You're muted now. Mr. Desolé, you're muted. We will suspend for a minute. Mr. Desolé, you seem to have frozen up. Are you there?
reacted. And I think that he might like to respond to the same question, which was how quick should we end our lockdown in order to have herd immunity? And how can we do it safely, given that we still don't have a vaccine, no antiretroviral treatment, and these serological tests are just getting up and running? So, Dr. Chabas, if you could take a stab at that question, please.
Peut-être vous enlever de mute.
Perhaps you're on mute, Dr. Chabas?
Thank you. One of the really profoundly unfortunate things about what's happened in Canada, where we in fact did the lockdown in advance of our outbreak, unlike many places in Western Europe or in the United States, is that in a sense we've had the worst of both worlds. We have achieved very little herd immunity, certainly no more than 5%, at least in the whole country. And yet we've had a lot of deaths. And we've had a lot of deaths because of the outbreaks in the long-term care homes. The population death rate in the city of Montreal is twice as high as it is in Stockholm, Sweden, and is actually starting to close in on the city of New York. So it's not been a very happy experience. So there are kind of two outbreaks. There's the long-term care outbreak, which drives mortality, and then there's the community outbreak where there actually has been very little mortality. But the fundamental question is it safe to reopen in the presence of active disease? No, not in the sense that we're not going to see more COVID disease. We will. When we start to open up, we're going to see more COVID disease. But the whole thrust of my presentation is look at it the other way. Is it safe not to open up? I mean, one of the earlier questions said, when are we going to open the schools, or why are we opening the schools? There's going to be more COVID spread. Well, the reason you open schools is because children have to go to school. It's a fundamental right of children to have an education. And if we deprive a whole generation of children of 6 months or a year of education, we're going to be paying the public health price for that for years to come. There is no nice solution. Dr. Fisman and Dr. Attaran, they talk about we do more testing, we do contact tracing, something which, by the way, has never been done to control a respiratory virus. It may work well in a spreadsheet. The real world is more complicated. I hope they're right. I hope they're right and that works. But the real world is a rather more complicated place. And as I say, what I'm really worried about is when they try this strategy, and the disease resurges in the fall, and the strategy fails, as I believe it almost certainly will, we can't go back into this kind of lockdown because we will do more long-term damage to our public health than COVID-19 could ever do.
Thank you, Mr. Theriault. We go now to Mr. Davies. Mr. Davies, you have the hammer.
Thank you, Dr. Chabas. You wanted a chance to kind of explain, so I'm going to put a few things to you. After SARS, you wrote, in the unlikely event of another SARS outbreak in Canada, public health officials should quarantine no one. Now, our current pandemic is a SARS outbreak. The virus is SARS-CoV-2, and we fought it mainly with lockdown and quarantine. So my first question is, are you standing by your extraordinary statement that we should quarantine no one? Now, before I get to that, I want to contrast that. In 1990, when you were the Ontario Chief Medical Officer, you classified HIV as a, quote, virulent disease, which is the worst category of characterization. And you recommended that we forcibly confine people with HIV who may have had sex with someone else, even if they used a condom and even if they disclosed that to their partner. And my final piece before I let you answer is, you said that we should treat this more like the 1957 flu, but the fatality rate in the 1957 flu was about 0.1%, which is about 1/12 that of COVID-19. So throwing all those together, can you help me understand your point of view?
I'll try to remember all of them. First of all, let me start with the SARS one and the quarantine. I was talking about SARS-1. SARS-1 was a disease which was not transmissible asymptomatically. It was not even transmissible in its early symptomatic stage. So quarantine made zero sense with SARS-1, and my hope was it wouldn't happen again. Yes, we've used it widely in SARS-2. Whether it's really been very effective or whether it's a useful tactic, because as I said before, you can maybe flatten the curve. In fact, I'm quite impressed by our ability to implement quarantine, and I think it probably has to some degree flattened the curve. But the question is ultimately, to what end? The virus isn't going anywhere, and unless the measures you're using to flatten the curve are somehow sustainable in the long term, I'm not sure they really get us anywhere. The third question related to HIV, yes, I had recommended, I didn't do it, it wasn't up to me. I'd recommended to the minister, excuse me, that it be classified in the same category as diseases like tuberculosis, syphilis, gonorrhea, hepatitis B. It was a classification which would give a judge the authority to incarcerate someone who was deliberately spreading the disease. That was the context of that. It actually never happened. There was this, I think, and that's not quarantine. Please understand, quarantine is when you lock someone up who you think is incubating the disease. Case isolation, which is a totally different thing, is when you know somebody has the disease, you take steps to isolate them. Now, I'm not recommending we do that for HIV. That's a different context. And that's what we do. In fact, when people have COVID, or we have good reason to believe they have COVID, we isolate them. That's not quarantine. Quarantine is when you lock them up when you think you're incubating them. The term quarantine itself derives from the 40 days of Lent. That's a medieval strategy. And by and large, I think it belongs back in the Middle Ages.
Thank you, Mr. Chair.
Davies.
Thanks. Before I have a point of privilege to raise before we adjourn, Mr. Chair. I would like to move a motion that this committee inquire into reports that a witness appearing before the Health Committee, Dr. Amir Ataran, may have been threatened, punished, intimidated, or otherwise harmed by the Public Health Agency of Canada, Statistics Canada, or the federal government in some other form because of testimony he has given at the Health Committee, and to determine if a prima facie issue of privilege has been raised, and if so, report such findings to the Speaker of the House. Mr. Chair, I'm quoting from Boskin Gagnon, which says this: the intimidation of a committee witness has also been found to be a prima facie breach of privilege. In 1992, a witness who had testified before a subcommittee was advised by a Crown Corporation employee that the issue of her testimony was being referred to the corporation's legal department. The witness informed a member who raised a question of privilege in the House. The matter was found by Speaker Fraser to be prima facie contempt and was referred by the House to the Standing Committee on House Management for consideration. In its report, it said this: the protection of witnesses is a fundamental aspect of the privilege that extends to parliamentary proceedings and those persons who participate in them. It is well established in the Parliament of Canada, as in the British Parliament, that witnesses before committees share the same privileges of freedom of speech as do members. Witnesses before parliamentary committees are therefore automatically extended the same immunities from civil or criminal proceedings as members for anything that they say before a committee. The protection of witnesses extends to threats made against them or intimidation with respect to their presentations before any parliamentary committee. Mr. Chair, I could go on. There are many more. So I move that there's been a violation of my privileges as a member of this committee, and I would ask that you act on the motion that I have moved.
Mr. Davies, you're in a point of order. You can't make a motion on a point of order. As far as the motion of the question of privilege, as I mentioned earlier, I believe that's out of scope for our authority to conduct these video conferencing meetings. We are restricted to solely to receive evidence relating to the government's response to COVID-19. And we are also allowed to make motions regarding the invitation of witnesses. So I certainly, as I mentioned before, I will take the matter under advisement, and I will look for a legal opinion from the clerk and the legal clerk as well, and we can take this up at another time. So I'll take that under advisement, and
Mr. Chair, I would like to raise a point of order. There were comments made in testimony today that I believe break parliamentary language, and it was deeply respectful to call Canada's public servant untruthful. That comment should be removed from the committee record.
Thank you for that point of order. Certainly, we are bound by the rules of Parliament in our conduct here, and I would certainly urge all participants going forward to be prudent in their language. So thank you, everybody.
Mr. Chair, back to Mr. Davies' point of order.
Go ahead.
In reading the motion adopted by the House of Commons sitting in Tuesday, March 24th, 2020, section F, it says, if committee is not satisfied with how government is exercising its powers under the Act, it may adopt a motion during a meeting by video conference or teleconference, report to the House by depositing report to the clerk of the House, which shall be deemed duly presented to the House on that day. So I would point to you, Mr. Clerk, or you, Mr. Chair, and then also the clerk to reference that point when coming back and addressing Mr. Davies' point of privilege.
And if I might, Mr. Chair, I want to be very clear that I am not raising a point of order. I am raising an issue of privilege. And I can further quote that it says in the
Just hold up, Mr. Davies. So thank you, Mr. General, for your contribution. I believe you did start your remarks, Mr. Davies, on a point of order, in which you then went into a point of privilege. It's kind of beside the point. I will take under advisement your motion, and we will get back to you once I have a ruling from the law clerk.
Mr. Chair, with respect, it's very important that you are misunderstanding my point. Earlier, I raised a point of order. I am now raising a point of privilege. And that's what I did in my second intervention. And you clearly have the power. In fact, you have the duty to receive my point of privilege as it's raised in committee, because this is where I have to raise that. I'm happy for you to go back and reflect on it, but I want to be very clear. I am raising a point of privilege, and I am asking for your consideration of the motion that I've moved.
Thank you, Mr. Davies. As said, I will take the matter under advisement, and we will get back to the committee in due course. So thank you, everybody. And thank you for our witnesses. It's been a lively and robust discussion. Thank you for sharing your time with us, and so much of it, indeed, and for putting up with our technical issues. And I would thank also the House staff and the technical people for being with us to work through those issues. And thank you for the members for all of their great questions. So having said that, thank you all, and have a good day. And the meeting is now adjourned.
Thank you.
Thank you.